Madhu sir, I will share the welcome screen.
Yeah, you can start sharing the welcome screen.
Yes, sir. Yes, sir.
We'll wait for Gopal Raju sir to join.
Right, sir.
And we'll start it in five minutes from now.
Right. So the live streaming is on.
చాలా మంది మా క్లాస్ నా బస్సులోనే వస్తున్నారు. మన ఏ క్యాంప్ కదా, నా ఫ్రెండ్స్ అందరూ వస్తున్నారు.
Playing from Madhu iPhone Mini.
Good evening, sir. Madhu sir.
Sir, good evening, sir. Good evening. Sir, we will start in 2 minutes, sir.
Okay, sir.
Once Gopal Raju sir joins, we can start, sir.
Okay, sir.
Anil sir?
Yeah, Madhu.
Sir, I think we'll 6:05 we'll start.
Yeah.
Start it with your introduction, sir. Anil sir.
Go ahead, Madhu.
Okay, sir. Okay. Sir, shall we start?
Yeah.
Okay. A very good evening to all of you. We welcome you to this Andhra Pradesh Ophthalmic Society Academic and Research Committee webinar in association with Visakhapatnam Ophthalmic Association on infectious keratitis. Now I request Dr. Anil sir to give his message before we start this webinar. Our ARC chairman, Dr. Anil sir.
Good evening, one and all. I think this was a hectic day for most of the postgraduates and most of the government hospital doctors who have taken in charge in judging many papers that was presented from morning 9:30 till maybe around 15 to 20 minutes ago. I welcome you all to the Academic and Research Committee webinar conducted in association with Vizag Ophthalmic Association on infectious keratitis. We have a special guest today, Dr. Lalita Prajna. She is the head of Ocular Microbiology Services at Arvind Madurai. And I welcome all the other cornea surgeons from the state of Andhra Pradesh. And thank you for agreeing at a very short notice. Madam, we shall start the webinar. Madhu?
We'll start this session. We have a small clip from Micro-Vision before that, and we'll start the webinar after it, sir. Our sponsors. Navneet, please play your corporate clip and we'll start this webinar.
Sure, sir.
Navneet? Can you play the clip now? Yeah. I welcome Dr. Gopal Raju, sir, the president of VOA and chairman scientific committee. Sir, shall we start the webinar, sir? Lalita madam is there.
Yeah, please go ahead. Please go ahead.
Sir. So, I think it's a great honor to introduce Dr. Lalita Prajna madam to our Andhra Pradesh State Ophthalmic Society and all the postgraduates. You know, Arvind has done a lot of landmark studies in infectious keratitis, especially the MUT study 1, MUT study 2, SCUT study. Any major study in infectious keratitis, Arvind was the one that has done a very large randomized controlled trials that were widely published. And I think if there is one person who stays out of the focus and is always behind all this is it's Dr. Lalita Madam. And thanks to her support from the microbiology side, we have so much of data that we are able to use today clinically and percolate it to clinical level knowledge. Lalita ma'am, welcome to APOS-ARC seminar. Please go ahead with your presentation. She'll be speaking on the update of ocular microbiology for ophthalmologists. She is our keynote speaker today from Arvind, Madurai.
Thank you, Madhu. And I thank the Andhra Pradesh State Ophthalmology Society and Visakhapatnam Ophthalmology Society also for this great honor. And I'm really privileged and honored to share my work on ocular microbiology, which we've done till now. So I'll just start sharing my.
Yes, ma'am. We are able to see. Yeah.
Okay. Yeah. So once again, thank you very much, Madhu, for this great honor that you all have given me to present my work on ocular microbiology and update. Thank the Andhra Pradesh Society also. So as all cornea surgeons, as all of you all are aware, this is a disease that we are talking about, infectious keratitis and the corneal ulcers due to various organisms. Such a high incidence we see all over our country, in every part of India. Nobody has a less incidence. So all of us have a very high number of cases that we see. And it's so important that all of us are kept abreast of what is happening. And such an update is really important. So my talk today for the next 15 minutes or so, I would like to first talk about the current incidence. Are we seeing a decrease or are we seeing an increase in the number of incidents of microbial keratitis? Also, the organism profile. Is it changing or is it remaining the same? Because this kind of information is very useful, especially if you're contemplating empirical treatment or you want to know the prognosis for that patient. Also, any newer organism. And then antibiotic susceptibility profile also is very important. But my main focus of this talk, I would like to really share with some of the newer diagnostic modalities which we are working on. So obviously coming from the laboratory side, we want our diagnosis to be more accurate, more sensitive, more specific. So that's what we are working currently on. And although I won't be obviously talking on newer treatment options, but as all of you know, as cornea surgeons, there are so many very exciting treatment options coming up for patients with infective keratitis, with all these different collagen cross-linking and other things. And then just a thought on these methods of prevention. So obviously we are very far from talking about prevention, but shouldn't we be even thinking about preventing microbial keratitis? Is it even possible? So maybe that's a topic for another update. Maybe 10 years from now, we would be talking about, really trying to eradicate this and trying to really prevent it. So now starting off with this incidence, we are all are aware of this iconic paper by Dr. Srinivasan sir. This is nearly 25 years. So this was the first paper which really brought into limelight the actual burden of this disease we're talking about. And at that time, it was like 50% of cases were mycotic keratitis in India versus 10% in the States. And this is the paper which really used the term silent epidemic. So corneal ulcerations in developing countries is now recognized to be a silent epidemic. And the incidence is definitely so much more higher than in the US. And Dr. M.S. was recently awarded the best scientist for all his work from the Stanford University. I'm sure you all might be aware of that. And then after that 25 years, we looked at the current data. That was again for the last 10 years from 2002 to 2012 to see. And that data showed that bacteria is definitely decreasing. But however, although we had assumed that fungus is increasing, it was not statistically significant as compared to the outpatient, and we compared it to the total actual number of outpatients we are seeing. And we attributed this to maybe because of that was the time when the fluoroquinolones were introduced, and maybe that was why the bacterial keratitis was coming down, seemingly coming down the incidence. And then recently there's a huge multinational study done by the Asia Cornea Society. So this was about 9 countries that participated, a prospective. This was one of the major studies of its kind, which really collected massive data from so many countries. And again, it showed that fungus was so common in China, India, whereas Singapore, Japan and all had more of bacterial ulcers. The etiology also was different, trauma for us, contact lens, these things for them. So just to share with you some statistics currently right now, for the last 6 years, where are we? So this is the number of cases we were seeing in the last few years. As you can see from these numbers, 2,400, 2,200. So an average of 2,000 cases we are seeing. So these are patients which actually came to the lab for the specimen had come to the lab for culture. So obviously many cases would not be sent to the culture. So maybe this numbers actually would have been more. So only from Madurai alone, one center, if we are going to see such a large volume, then you can imagine the actual numbers in the rest of the country put together. And looking at the number of culture positive, so this first line is fungus. So that is always around 60 to 65% is an average, and bacteria is 30% among the culture positive, that is. And this 2% is actually amoeba. I'm sorry, this 2%, so amoeba, acanthamoeba keratitis is around 2% of cases we see every year. And the organism profile. So again, we are always keeping an eye on what is the trend. Is there any change in the incidence of organisms we are seeing? So maintaining such a kind of data has really shown us. See, in 2013, this is pneumococcus. The first bar is pneumococcus, streptococcal pneumoniae, and Pseudomonas is way down. And in 2014, 15, you can see the trend gradually changing. And now 2019, Pseudomonas has now become slightly more in incidence than pneumococcus. And this is actually attributed to the increase in the number of contact lens. So which is really, very interesting data information that we are getting now. So contact lens usage is now increasing, or the type of contact lens, or the hygienic conditions, patients' awareness of contact lens usage, all that is yet to be studied and known. But this microbiology data clearly shows us that something is happening between Pseudomonas and pneumococcus. It's come down and Pseudomonas is going up. So that's a very interesting information that we're getting nowadays. Whereas in fungus, it's still the same. So even for the last 25 years also, Fusarium was always the commonest, followed by Aspergillus flavus. And the third most common is something what we call as unidentified hyaline and dermatitis, meaning that we cannot identify. And this Pythium is something now everyone's talking about, and that incidence about 1.9%. Candida is very, very, very less for us, as could be expected. So in the spectrum of fungal organisms, not much change. Coming to the antibiotic sensitivity, so again we can see among the fluoroquinolones, I will just highlight only the moxifloxacin, and that's the preferred drug empirically at least, and that's a broad spectrum. Everybody starts that as the first line of treatment. For pneumococcus, that is still maintaining the sensitivity very well, and vancomycin is also 100% sensitive to pneumococcus, and streptococcus pneumonia actually on the whole is quite sensitive. I'm just showing the sensitivity only for gram positive and 1 gram negative. So since Pseudomonas is the most commonest gram negative organism, again, fluoroquinolones are quite sensitive. The sensitivity has been maintaining for the last 5-7 years, around 95%. So any of them can still be used for treatment. Now coming to the changing trends and any novel organisms we are seeing. So other than these new funguses, suddenly some new fungus will crop up and we will sequence it and identify it. But this one organism, Microsporidia, which was really suddenly came out, and now it has now become a prevalence. So it is now a general disease. We're seeing a lot of cases. I'm sure all of you all also must be seeing. I'll just show you the data. So 2006, it was initially starting to be reported only in early 2000, 2002, 2003, when all these HIV related keratitis started coming. We saw only one patient. 2008 also one, 9 also one, 10 also one. Suddenly in 2011 only, at the end of 2011, this was like November, October, November, and then suddenly it started peaking up. And 2014, we saw the maximum cases, and now it has become static with a plateau. After 2017-18, doctors are not even sending samples to the lab. So we don't have the data, accurate data after 2017-18, because now it has become very common. Everybody can recognize it. They're not sending it. So that's one interesting disease which we are seeing nowadays. Now, Pythium is another fungus. I'm sure all of you are very interested. I get so many questions about it. And so because of obviously the poor prognosis and not responding to the routine antifungal need to the use of antibiotics. But this is very easily recognizable, very easily grows on culture. You can see the zoospores forming. So that's another interesting. We've seen about 150 cases as of now of Pythium keratitis. Now coming to the laboratory techniques, and so I just wanted to, so this is starting from the conventional microbiology, which is still the gold standard, and we still have to rely on it. So whatever latest techniques come, we still can't do away with this. And as all of you are aware, direct smear is very, very important. And I really like to highlight this point in every talk I make, culture on standard media and molecular diagnosis. Coming to the molecular diagnosis, many times we are very frustrated. Culture is always negative. So culture of sensitivity is suboptimal, around 50%, although the specificity is 100% and requires time. So everybody wants to do a PCR. So is PCR really going to help in the management of corneal ulcer? That's a very, very important question we really have to ask ourselves. Just a quick thing on, this is very familiar to everyone. So PCR obviously detects nucleic acid and it's very sensitive. And it's especially ideal for situations like corneal ulcer where the specimen is very scarce. We have the different types, conventional, real-time. And the real-time is much more advantageous than a conventional PCR because we can know the copy number and we know the, so whether it's an active or a latent infection. But the thing with PCR is, so I would like to tell this point because in my later slide with another technology, this would vary. In a routine PCR, we have to have some knowledge or suspicion of a particular organism. So we have to suspect, do we want to do PCR for bacteria or do we want to do PCR for fungus? And then if you look at the literature on what is the sensitivity and what is this thing of utility of PCR in infective keratitis. So we did a study, it's nearly 10 years now. We found because bacteria and fungus are so ubiquitous in the environment, even in the air around the patient, patient's cornea itself might harbor some non-pathogenic organisms. So that is why we saw a very high rate of false positive. So this is a point you should really bear in mind if you're going to use PCR in one of your diagnoses. So PCR has got a lot of issues. The extreme sensitivity leads to a lot of false positive. The specificity leads to a lot of false negative. And it cannot differentiate between active and latent infection. And every step would affect the PCR. Now coming to the future of microbial keratitis. So this is what I would really like to emphasize my talk on. Is there a future and what is the future? So I have these 4 points to really say that this is going to be the future. So the reimagining the future of diagnosis of microbial keratitis with alternative strategies. So although as I emphasized, conventional culture is still going to stay, we have next generation sequencing, the latest technology in molecular testing. And then nowadays we have something called as personalized medicine host biomarkers that is looking like cytokines, MMP, mRNA, that is clinical proteomics. Our lab has been doing proteomics work for nearly 10 years now. And then also we are experimenting with something called as smart probes. So this is actually going to be the point of care use in remote resource limited countries. So as we all know, by the time the patient comes to us is definitely at least an average of 2 to 3 days. So now we have all these vision centers, primary health centers. So can they be given something where immediately they can know whether it is bacteria or fungus and just start some early treatment? And then artificial intelligence cannot be far behind. Every disease, every aspect in life is ruled by artificial intelligence. So we are also studying that to see whether we can use that approach in the diagnosis. So next generation sequencing, just to give a brief, very, very brief, because it's a very complex technology. So what it does is, you don't have to have a prior knowledge of whether you want to check for bacteria, fungus, virus, or the host DNA. So it just sequences all the possible nucleic acid which is going to be there in your specimen. And then so any foreign DNA within the sample, everything is detected. And the advantage of this is you can even discover novel pathogens, especially multiple pathogens. So now actually nowadays the thinking is only the organism which is really present in abundance is growing in culture. Actually, there might be so many other pathogens which are all interacting with each other and causing this disease progression and affecting the prognosis. And they don't grow in culture because they're present in less quantities. So this next generation sequencing will help us pick up these multiple pathogens. And then we can do targeted sequencing, metagenomics, look for antibiotics. You can do anything you want. The only bottleneck in this technology as of now is the specialized equipment needed. The cost factor is enormous cost is involved. And another thing is you need people with bioinformatic knowledge, because all these sequencing have to be analyzed using so many software, and you need a bioinformatic background in that. But however, this is predicted to be the future in clinical microbiology. And especially when pandemics like COVID and all come, that is what made it so easy for them to immediately sequence the coronavirus. And they knew it within a matter of hours what strain it was. Any new strain which is coming also, you can immediately know whether there's a new strain, how many mutations are happening. So this is the technology which everybody is using all over the world. So we just published 2 papers on that. One we did for conjunctivitis. So although we know conjunctivitis adenovirus is the most common, it also picked up a lot of microsporidiasis, which the clinicians never suspected. Everybody assumes every conjunctivitis is adenovirus. But since microsporidia is so high for us, we also saw a lot of conjunctivitis due to that. And more importantly, we were able to see a lot of difference in the whole host transcriptome. Adenovirus had a different transcriptome, microsporidia had a different transcriptome. So that itself will help us in identifying what is the organism responsible. And then this recent paper was the same technology used for keratitis. So this we did a prospective study, and this metagenomics identified pathogens. So the sensitivity of this compared to culture was much more. So this was nearly 75 to 80% more positive compared to culture. And then also, as I said, it picked up some different kinds of organisms. Now coming to the proteomic study, targeting host biomarkers, Dr. Prajna is really passionate about this. He feels that this is the future, and he feels personalized medicine is the way. So it's not like everybody has the same pneumococcus, same fusarium. It has to be something different. And actually this is showing. So this shows that this one protein called zinc alpha-2 glycoprotein. This can help in differentiating flavus and fusarium. And then also the complement factor H. So for the last few years, we've been working extensively on this. And this is really helping to predict the outcome. So all the patients which have a poor outcome go in for a perforation or require keratoplasty. We found that the complement factor was more elevated in those patients. And then also this other microRNA, mRNA as it's called. So this is another approach in both in diagnosis and prognosis and for treatment. So microRNA actually is now come into treatment aspects in many oncology setups like liver cancer and some kind of prostate cancer. Already they're using microRNA molecules for treatment. So we are also seeing whether there is any role for it in infective keratitis. And then the last but the final thing is about these point of care probes. So these are nothing but just fluorescent dyes, which is targeted towards bacteria or fungus. So this accurate, rapid point of care infectious using smart probes. Smart probes means it's not like a actual probe kind of thing. just the dye only is called as a probe. So this is the microbiology picture of this, using this fluorescent probes, how they're going to be seen. But the actual concept is this is going to be put in a small box with a small light source. And so if the vision center technician or somebody can just take a small swab with a cotton bud and put it on the slide, and it'll just fluoresce if it is bacteria, different colors. So we did a pilot study on that also. And we found that these smart probes are equivalent or even better than gram stain in picking up the bacteria or fungus. So we're just fine tuning this little more and trying to take it to the ground level to see, to take it to the field to see whether it's really going to work. And finally, as I was saying, this is the current project which we are doing, metagenomic analysis for rapidly identifying fungal and bacterial keratitis with artificial intelligence. We are calling it the Madurai study. So this has recently been funded, and this is currently ongoing. The objective of this is to develop and validate artificial intelligence systems for the diagnostic evaluation of corneal ulcers. And so the outcome would be to see whether there is an agreement between the AI system and the technician in interpreting the KOH and gram stain. So for this, obviously, as you know, we require a large number of samples, at least about 1,000 to 2,000 cases are needed to develop the data for the system to work. And then also use photographs also. So both the gram stain and KOH and clinical photographs. So this is the kind of data that's going to be fed into the system for it to understand how to do this. And so that comes to the end of my talk. To conclude, the future is probably multi-dimensional. Maybe it just can't be one approach alone. So that's what this is the, the buzzword in America and all, is precision medicine, what they call. So they want it to be very personalized, very precise. So maybe molecular diagnostic, point of care, next generation sequencing, targeting host biomarkers, artificial intelligence. All this might all come into some kind of, as one system to help us in better diagnosis of these diseases. Thank you, and that's the end of my talk. Shall I stop screen sharing, Madhu?
Yes, ma'am. Thank you. Thank you so much. I think the way in which you are telling that this point of care diagnosis will come, it will be useful to most of the private practitioners or single practitioners where they usually don't have microbiological backup. If this comes like a ready-made kit kind of a thing, I think the diagnosis will be more easier and the treatment would improve and it will be more precision, as you have mentioned. Thank you so much.
Yeah.
Any other questions from the panelists? Gopal Raju sir and any of the corneal surgeons who are there?
Yeah, that was an excellent talk, madam. Very enlightening. First of all, thank you for sparing a Sunday evening.
No problem, sir.
And I'm very fortunate and then to be associated with your lab. I've seen right from the single room drawing blood from the live goat. I was one of the person who has really started that sucking the blood from the goat and then preparing the blood agar.
Yes.
And then now you have reached up to the PCR and then DNA level. That was congratulations for taking the lab to such an international standard level. The number two, madam, my personal feeling is I think we have advanced quite far in the diagnostic aspects, like diagnosing the microbiological agents. How far we have reached in the case of the antibiotic sensitivity or the anti-infective sensitivity? That was one question. If you can enlighten us in that, that is one. Number two, even though we have the commonest is the fungal agents, and being an agricultural nation, we still see a lot of fungal corneal ulcers, and it's very disgusting to manage such ulcers because still whatever you diagnose the number of species or the many things, but still the availability of the antifungal agents is limited to only 2 or 3. There our hands were really tied as a clinician. In these 2 aspects, if you can just add few points and then update us, I think it will be useful. Thank you, madam.
So actually, the first question I didn't understand, sir. First question was you wanted to know about sensitivity?
Yeah. See, in the after the culture, so we were doing an antibiotic sensitivity, for example, in bacterial for the aminoglycosides or the cephalosporins and whatever it is. So the ground in vivo effectivity of the translating of that antibiotic sensitivity report to the clinical
Okay,
application.
Yes, yes, I understand.
I feel there was some gap.
Yes, yes, I understand that point. Actually, that is a major point for debate because this reporting, as you're all aware, is based on the serum level, and whether it's applicable to ocular infections, where the concentration is the actual concentration is received, there is no breakdown, there is no lag time. So, does it really make sense when we report it as resistant? So, if the patient is responding very well, then why do you want to change? And so I think that's a question now everybody's asking in all the labs. What is the significance of reporting this? Because we are only left with using the serum concentration, serum levels only we have to report. So even if it's resistant, especially all the moxifloxacin to gram positive shows high resistance nowadays to staphylococcus and all.
Okay.
But that's actually for the serum concentration. So I feel if patient is responding to the drug, do you want to change it just because it shows a resistant report? That's a quite distinct to.
So there is a huge gap in still the improvement of the sensitivity, antibiotic sensitivity.
Yes, yes, yes.
Because sensitivity is, as madam told, is specific to serum, sir. We cannot rely on that results for our corneal concentration. And actually, in our experience, the older drugs are working better. Chloramphenicol, polymyxin. If the ulcers are not responding to moxifloxacin and gatifloxacin, when we go back to these older drugs, most of them are being sensitive. Probably those drugs are not as misused as our newer drugs.
Yes, yes.
And coming to your second question, sir, unfortunately, as we are just still stuck with those 2-3 antifungal, and we totally understand the clinician's frustration in that. But that's what our proteomics approach is. That's what is going to, all these mRNA and TR proteomics. Can we come up with some other therapeutic choice? So the treatment is obviously always a challenge.
Yes.
Unfortunately, we are still looking at newer antifungals, not so easily available.
Yes, yes.
Thank you, madam.
Okay,
thank you so
very
much. I think madam has one more commitment, sir. She'll be leaving now.
Oh, sure. Thank you very much, madam, for squeezing us that tight schedule.
No, sir. I only should be thankful to you all for inviting. Thank you for remembering to call me. It's very nice to see all the familiar faces.
Yeah, sincere thanks and on behalf of the APOS as well as from the Vishaka Ophthalmic Association.
Thank you, sir.
Thank you, madam.
Thank you very much, madam.
Thank you, Anand.
Now I think we can go to the next talk by Dr. Nasreen ma'am from Sankar Foundation. She'll be elaborating about the diagnosis and management of bacterial keratitis.
Madam, can you share your presentation?
I'm looking for that.
Okay.
Is it okay now?
Ma'am, you can go full screen. Slideshow.
It's full screen only. Full screen only.
Yes, ma'am. It is full screen now. Yes, yes.
Okay. Okay. Good evening, all. First of all, thank APOS-ARC and VBOA for giving me this opportunity. Corneal ulcer is defined as a breach in the continuity of the corneal epithelium associated with necrosis of surrounding corneal tissue. Corneal ulcer is the second commonest cause of preventable blindness next to cataract in Asia, Africa, and Middle East. Corneal opacities due to infectious keratitis is the fourth leading cause of blindness globally. Microorganisms cannot penetrate intact corneal epithelium except gonococci, Corynebacterium diphtheria, Haemophilus, and Listeria. So common predisposing factors are risk factors that disturb corneal epithelial integrity, such as contact lens wear, trauma, contaminated ocular medications, impaired defense mechanisms, altered structure of corneal surface. Ocular defense mechanisms are bony orbit, eyelids, normal conjunctiva, corneal epithelium. Those are anatomical barriers. Tear film mucus layer, lacrimal system. Those are mechanical barriers. Tear film constitutes IgA, complement components, lysozyme, lactoferrin, and beta-lysine. And conjunctiva associated lymphoid tissue, these act as antimicrobials. Exogenous infection comes from conjunctival sac, lacrimal sac, infected foreign bodies, infected vegetative material, waterborne, airborne infections. This is from conjunctiva readily spreads to corneal epithelium, from sclera to stroma, and uveal tract to endothelium because of the anatomical continuity. Endogenous infection is rare because cornea is a avascular structure. Many organisms may affect cornea. Among them, most common are Staphylococcus aureus, Staphylococcus epidermis, Streptococcus pneumoniae, Pseudomonas aeruginosa, and Enterobacteriaceae. Pathogenesis is determined by virulence of the organisms, bacterial load, and sensitivity to commonly used antibiotics. Host factors such as immune status of the host, septic foci, and therapy effect also determines the pathogenesis. Once breach happens in the corneal epithelium, microorganisms gain access into the stroma, release cytokines and interleukin-1. This attracts polymorphs. This release proteolytic enzymes which cause keratolysis and stromal necrosis, leads to corneal ulcer. If increased IOP, it leads to perforation. Pathophysiology is like this: stage of progressive infiltration, stage of active ulceration, stage of degradation, and stage of cicatrization. Symptoms are pain and foreign body sensation due to mechanical effect of the lids, chemical effect of toxins on the exposed nerve endings, watering due to reflex lacrimation, redness due to congestion of the circumciliary vessels, photophobia due to intolerance to light, which results from stimulation of nerve endings, blurred vision due to corneal haze. Bacterial ulcers are typically single infiltrate with sharp epithelial demarcation, underlying dense suppurative stromal infiltrate with indistinct edges, and stromal edema. Floor of the ulcer is covered with necrotic material. Grading clinically graded as mild, moderate, severe, depending upon the size of the ulcer, depth of the ulcer, stromal infiltration, scleral involvement. Many pyogenic organisms may produce hypopaean. Hypopaean is collection of pus in the anterior chamber. Most dangerous organisms are Pseudomonas and Pneumococcus. Source of infection for pneumococcal infection is usually chronic dacryocystitis cystitis. Two main factors which predispose development hypopaean are virulence of the infecting organism and resistance of the tissues. Hypopaean ulcers are common in old, debilitated, and alcoholic subjects. Characteristic hypopaean corneal ulcer caused by pneumococcus is called as ulcus serpens. It has tendency to creep over cornea in a serpentinous manner. Spreading it shows more infiltration. The other side of the ulcer may go cicatrization simultaneously. Early chance of perforation and secondary glaucoma. Staphylococcus most commonly seen in compromised corneas. MRSA is increasing in refractive surgeries. Staphylococcus epididymitis is showing indolent course. It may also lead to stomal abscess. Pseudomonas is most common gram-negative organism. It is increase in prevalence with contact lens use, mostly in extended wear contact lens users. Rapid progression with dense ring infiltrate, liquefactive necrosis later leads to desmatocyl formation and perforation. Stromal edema surrounding gives the ground glass appearance. Nocardia is acid-fast and gram-positive bacilli in branchy filaments. It is characterized by multiple pinhead-like infiltrates in wreath-like configuration. Non-tuberculous mycobacteria, these are slowly growing keratitis, delayed onset of symptoms, lack of response to conventional treatment, delay in diagnosis, and heal very slowly. Mostly after corneal surgeries or corneal foreign body after LASIK procedures. Infectious crystalline keratopathy, characterized by white crystalline bacterial colony within the corneal stroma. A low virulent organism gains entry through a suture tract or injury and starts proliferating along stromal lamellae, but fails to incite inflammatory response. It is seen in graft rejection adjacent to corneal grafts adjacent to sutures and in post-LASIK procedures. Complications of corneal ulcers are absorption of toxin in antechamber leads to toxic iridocyclitis and purulent uveitis. Fibrinous exudates blocks the angle of the anterior chamber, leads to secondary glaucoma. Virulent organisms extend rapidly up to Descemet's membrane, which gives a great resistance, but herniate due to IOP. It is called as desmatocyl here. Sudden rise of IOP due to cough, sneeze, or spasm of ocular orbis leads to perforation of the cornea. Infection spreads to intra and extraocular structure, leads to endophthalmitis and panophthalmitis. Sudden lowering IOP because of perforation may give to hemorrhage of atherosclerotic blood vessels, which leads to vitreous hemorrhage or expulsive choroidal hemorrhage. Sequelae of perforation depends on the size of the ulcer. Small and opposite to iris tissue, iris goes and plugs the perforation, heals rapidly, leads to adherent glaucoma. Perforation in the pupillar area, if it is not plugged by the iris, it is lined by epithelium, which gives way repetitively, leading to corneal fistula, which continuously leaks. Perforation in the pupillar areas, lens suddenly comes and touches the ulcer, leads to anterior capsular cataract. Large sudden perforation may give to subluxation or anterior dislocation of lens because of sudden stretching and rupture of the joinures. Near total ulcers due to high virulent organisms or low host response exudates, organizes, and forms pseudocornea, which cannot withstand the IOP, and ectasia happens. It is called as antistaphyloma. Management of corneal ulcer. First, we have to take detailed history, onset and symptoms, degree of pain, redness, discharge, photophobia, duration, circumstances surrounding onset, such as history of injury or a foreign body, and systemic examination for immunocompromised state, septic foci, and ocular history of contact lens usage, surgery, trauma, dry eye, adnexal infection, and examine general appearance of the patient for any skin abnormalities over skin, facial palsy, eyelids, lid closure, etc., and document visual acuity. Slit lamp examination includes lid margins for any mebomitis, blepharitis or trichiasis, ectropion, entropion, and any lagophthalmas, tear film for any mucous debris, and conjunctiva for any foreign bodies, congestion, edema, cicatrization, papillae, follicles, etc. Scleral examination for any nodules, inflammation, or any ischemia, cornea for any foreign bodies, epithelial defect, abrasions, or any delay, and thinning, perforation, and infiltrate, and for corneal sensations. Location may be central, peripheral, or perineural, and adjacent to trauma, surgery, etc. Make a note of density and size and shape. Ring ulcers or satellite lesions in case of fungal ulcers, and depth and character of infiltrate, suppurative, feathery, soft, or crystalline, color of the infiltrate, and endothelial plaques, keratic precipitates, AC cells of layer, fibrin, hypopene, etc. Iris color pattern and lens details, regurgitation test, and syringing of the sac. Rule out any foreign bodies or exposed or broken sutures, any signs of corneal dystrophy, which leads to recurrent corneal erosion. Previous corneal information such as thinning, scarring, neovascularization in case of viral ulcers. Previous refractive surgeries, fluorescein or rose Bengal staining for any dendrites, pseudodendrites, or loose sutures, and intraocular extension of or endophthalmitis, and examine contralateral eye, any evidence of dry eyes, etc. Laboratory investigations includes routine blood investigations, and specific investigations include corneal scraping for smear examination and culture. Corneal specimen is usually obtained by heat sterilized platinum spatula, which we are not using. We are using 15 number blade. From the advancing edge of the ulcer, we have to take the infiltrate and do smear examination. In case of culture, we have to directly inoculate over the culture media because the collected material will be less, and it should be inoculated in C-shaped strokes. Smear examination includes gram stain and for bacteria, Jaden stain for if we suspect mycobacteria, KOH mount in case of fungal ulcers. Cultures are indicated in case with large corneal infiltrates, deep stromal infiltrates, chronic nature, and unresponsive empiric treatment. Clinical features suggestive of fungal, amoebic, or mycobacterial keratitis. Blood agar and chocolate agar normally used for bacteria. Several textiles is used for fungal ulcers. In case of deep mycotic keratitis, intrastomal abscess, staining and culture comes negative, so we have to do corneal biopsy under topical anesthesia with 2 to 3 mm punch or dermatological punch. We have to do corneal biopsy and make it into 2 halves. Send one for histopathological examination and one for culture. In vivo confocal microscopy, bacteria typically not visualized but characterized by activated keratocyte with the infiltration of leukocytes and Langerhans cells. It is not mostly used in amoeba. Treatment ideally started before definitive diagnosis obtained because we have to reduce the bacterial load and minimize the visual disability. Initial therapy is empirical with topical broad spectrum coverage. Topical fluoroquinolone initially began every 30 to 60 minutes and that tapered in frequency according to the response. Sometimes even we have to give every 5 minutes if severe ulcer is there. This is to achieve therapeutic concentration in corneal stoma. Fortified antibiotics may be used when ulcer MRSA is suspected, large or vision-threatening ulcers such as in central ulcers with prior antibiotic failure, because we can achieve higher levels in corneal stoma, but they have greater toxic effect on ocular surface. Treatment includes monotherapy and combination therapy. Monotherapy, if ulcer is less than 3 mm in diameter, peripheral location not involving visual axis, not associated with thinning. In combination therapy, one active agent against gram-positive, another active agent against gram-negative bacteria. In case of monotherapy fails, or in at initial presentation, ulcer is large, vision-threatening, and atypical nature, we have to use combination therapy. Second generation fluoroquinolones, ciprofloxacin, ofloxacin, levofloxacin, they are excellent at gram-negative organisms, but limited value with gram-positive coverage. Gatifloxacin, it has improved gram-positive coverage, but it is good at gram-negative coverage. Moxifloxacin, becifloxacin, they have improved gram-positive coverage, retained gram-negative coverage. If there is no organism identified or multiple types of organisms present, better we have to give combination therapy with cefazolin for gram-positive coverage and tobramycin, gentamicin, or fluoroquine, anyone for gram-negative coverage. These are the different type of antibiotics. Vancomycin and bezitracin have no gram-negative activity, but they are good for resistant enterococcus and staphylococcus and can be used in penicillin allergy patients. Now, trend is shifting towards fourth generation fluoroquinolones monotherapy because fluoroquinolones demonstrate added advantage over fortified antibiotics in terms of better stability, longer shelf life, and less epithelial toxicity, with added advantage of not requiring refrigeration and broad spectrum, which includes both gram-positive and gram-negative activity. Systemic antibiotics are not required except in severe keratitis, scleral involvement, impending perforation, frank perforation with intraocular spread in children, and in Pseudomonas infection. Non-specific treatments such as cycloplegics to relieve ciliary spasm, systemic analgesics, and anti-inflammatory to decrease edema and pain, vitamins A, B, C for early healing, physical and general measures such as heart fomentation, dark goggles, etc. Monitoring of the response depends upon these clinical parameters such as blunting of the perimeter of the stromal infiltrate and more defined and demarcated margin due to decreased density of the stromal infiltrate, reduction of the stromal edema and endothelial inflammatory plaque, reduction in anterior inflammation, re-epithelialization, and cessation of corneal thinning. Uncomplicated corneal ulcers leave a scar with different densities called as nebula, macula, and leucoma. Role of corticosteroids is controversial because steroids are effective at modifying the inflammatory response, but they also inhibit the host response to infection. They may be associated with improved long-term clinical outcome in bacterial ulcers not caused by Nocardia species. Newer modalities such as collagen cross-linking and phototherapeutic keratectomy have promising results. Treatment of impending perforation, better to avoid strain, strict bed rest, pressure bandage for external support, and lowering of IOP, tissue adhesives, conjunctival flap, bandage contact lens, and tectonic grafts. Summary of treatment: keratitis at presentation. If it is small peripheral ulcer, no microbiological workup is required. We can use broad spectrum antibiotics. Fortified or commercial preparations such as fluoroquinolones. Center ulcer or multiple ulcers or deep ulcers, microbiological workup has to be done and specific antibiotic to be given. Reassess after 48 hours of treatment. Stable and are improving, continue the same treatment. A significant progression is there. If poor compliance, institute alternative treatments such as subconjunctival injections or systemic antibiotics or good compliance. Initial workup has been not done. Stop medication for 24 hours. Do microbiological workup. Start antibiotic according to sensitivity. Good compliance is there. Initial workup has been done. Check culture reports and modify the treatment accordingly. Review after 1 week. Complete resolution is there. Stop medication. Stable but incomplete resolution. Initial workup has been done and culture is negative. Then decrease the antibiotic, treat ocular surface, and use unpreserved medication. If culture is positive, decrease antibiotic, treat ocular surface, and use unpreserved medication and modify antibiotic. If no workup has been done previously, stop medication for 24 hours and do workup and modify the antibiotic based on the culture. If still progression is there, previous culture is negative, stop medication for 24 hours, suspect polymicrobials or unusual organisms. Again, repeat culture or do corneal biopsy and modify antibiotic. Progression is there. Previous workup has been done, culture positive. Then suspect emergence of resistant strains or polymicrobials. Modify antibiotic, repeat culture and check sensitivity. Non-healing corneal ulcer causes may be local or systemic. Local includes raised intraocular pressure, concretions, misdirected cilia, impacted foreign body, dactylocystitis, inadequate therapy, and wrong diagnosis. Systemic such as diabetes mellitus, severe anemia, malnutrition, chronic debilitating diseases, patient on systemic steroids. Treatment is removal or treatment of underlying cause, mechanical debridement of ulcer, cauterization, but it is not practicing now, bandage soft contact lens, peritomy to sever the limbal vessels, which hinders the healing. Okay. Thank you very much.
Thank you so much, ma'am. I think you have comprehensively covered every aspect of bacterial keratitis. Before we go to fungal keratitis, sir, any questions from the panelists and any experience with high concentration levofloxacin that is recently launched by any of the corneal surgeons in the panel? Meanwhile, Ramya, you can share your presentation. Any experience, Gopal Raju sir, Raghava?
You ask Navneet to post questions posted in the YouTube.
Yes, sir. Yes.
Yes, sir. I'm just looking ahead, sir. Yeah.
Yeah. So anybody having experience with high concentration levofloxacin that is recently launched? Nazreen ma'am?
No. We were using cefazolin, but it is not available now.
Yes, madam.
Then
Sir,
we shifted to moxifloxacin and if required ceftazidime.
Okay.
But we are facing more fungal ulcers than bacterial ulcers.
Yeah. Bacterial nowadays it has come down a lot.
Yes,
Sir, Sriram Chandramurthy sir, any experience with high concentration levofloxacin, 1.5%? Raghava?
No, sir.
Sir?
No, Madhu, I have not used that.
It was recently launched by Santon, sir. I don't think they have still come to Andhra. I don't see anybody using it. But in North, they're using it, I think, sir.
Only gatifloxacin is available, sir.
After quick,
High concentrated gatifloxacin.
higher strength is available, sir. But levofloxacin, they have come back with 1.5%.
but we did not get it.
So far, I don't think Santon has started its marketing in Andhra.
Madhu, is there any role of Ocular eye drops? Actually, Dr. MS sir used to say it's having a broad spectrum antibiotic. Actually.
Yes, sir. Ocular is chloramphenicol.
Yeah. Still, what is the role in the bacteria?
It has role, sir. In most of the resistant cases, it tends to work. Chloramphenicol and polymexin combination.
Yes.
It has a good role, sir.
Okay, thank you.
Another important point about chloramphenicol is it is a bacteriostatic drug, and we usually should not combine with bactericidal.
Yes.
Do little be aware about the time.
Yes, sir.
Request
Ramya?
all the.
Yes, sir.
Let us first complete the talks, then we can have.
Yes, sir. Yes. Ramya, please go ahead with your presentation.
Sir, as of now, there is no question from the audience.
Thank you, Navneet.
Right, sir.
Okay, thank you, sir. Can you see my screen?
Yes, it's visible. You can go ahead.
Okay. Good evening, everybody. Today we'll be looking at some of the basics of fungal keratitis in the next few minutes. I have no financial disclosures. We'll be looking briefly at the epidemiology, the etiopathogenesis, the clinical features, and the medical management of fungal keratitis. And we shall also take a quick look at some of the major trials, the landmark trials in fungal keratitis. So as we know, this is a disease of the tropical countries. The hot and humid climate favors the spread of the fungus. Most of it occurs in the 21 to the 50-year-old age group. That is the active group that goes out to work and hence is more prone to trauma of any sort. Again, it's more common in men for a similar reason. The male to female ratio is 1.5:1. There's a seasonal variation as well. It's more common in monsoons, early winters, and in windy climates. Then in one study conducted which looked at the various studies published across the world, they were highest proportions of fungal infections from those studies published from India and Nepal. We also have a geographic variation, that is in the northern and the eastern parts of the country, Aspergillus infections are more common, whereas in the southern part of our country, Fusarium infections are more common. In the central India, both Aspergillus and Fusarium are of equal preponderance. Again, in the western countries, there's a lot of Candidal infections, that is, they're more common in the temperate climates rather than the tropical climates like us. Then overall for us, Aspergillus keratitis is the most common organism causing keratitis. Then this picture is from a recent publication from the Survey of Ophthalmology. All the blue squares indicate the location of studies which have reported predominance of bacterial keratitis. As you can see in the West and in the Europe, there is a lot of bacterial keratitis, where the green triangles indicate fungal keratitis. And in our country, as well as in South and Southeast Asia, there's a lot of fungal keratitis. And that's the reason we are more concerned about fungal keratitis. Then as we know, trauma with vegetative matter is the single most important predisposing factor to fungal keratitis, which is most common in the agriculturist community. Then a local compromise like a prolonged epithelial ulceration, as in the case of a persistent epithelial defect or a neurotrophic keratopathy, zoster keratitis, etc., can all predispose to fungal infection. Systemic conditions like vitamin deficiencies, alcoholism, HIV, etc. interfere not only with the local immune response, but also with the healing capacity. Hence, they form predisposing factors. And usually whenever a patient walks in with some kind of trauma, there's also, he admits to the usage of some kind of over-the-counter which usually includes dexamethasone as well. And also there is an injudicious prescription and usage of antibiotics also, which all predispose to fungal keratitis. Again, corneal surgery and contact lens use are among the other predisposing factors. Then in this table from the publication in Indian Journal of Ophthalmology, these looked at the various causative agents of trauma in about 120 fungal ulcers, and they saw that more than 85% were caused by trauma with vegetable matter of some sort, followed by cow tails, injury with nails, flying insects, metallic substances, soil and dirty water, and so on. And broadly, if we have to classify fungi based on the fungal keratitis perspective, you can classify them into filamentous and yeast-like fungi. Filamentous fungi again have septate and aseptate fungi, where septate fungi have Moniliaceae and Dematiaceae, that is the pigmented ones. And among the Moniliaceae, we have Aspergillus and Fusarium, which are the most common causes of keratitis in our country. And among yeast, Candida is the most common cause of keratitis. After the injury with vegetative matter or trauma due to contact lens usage, with or without the presence of a local or a systemic compromise, there is the adhesion of the fungus to the cornea by means of the adhesins. And once there's adhesion, there's penetration by means of toxins, enzymes, and direct growth of hyphae into the lamellae and across the lamellae as well. These might as well penetrate the intact decimase membrane and can gain entry into the anterior chamber, after which eradication of the fungus becomes really difficult. Then there's the host response as well. Initially, it is poor because of the avascularity, and also there's a time that occurs before the immune response comes into play, and this is thought to be because of the size of the fungus. A fungus is much larger when compared to a bacterium. And once the polymorphonuclear leukocytes come in, there is enzyme release and stromal necrosis. So clinical features, as in any ulcer, would include pain, redness, defective vision, etc. But here the symptoms are much lesser when compared to the signs, as we know. And also when compared to bacterial keratitis, the symptoms are much lesser. And the pain and inflammation, as I said, are less in the early stages. Now, this is the more important part. If we look at the picture on the left, initially a fungal keratitis might resemble a dendrite, and this is termed a pseudodendrite. And it can be differentiated from a true dendrite in that there are no terminal end knobs and there is no dichotomous branching. And a viral keratitis would just look like an epithelial breakdown, whereas here you have an actual infiltration. So this is termed a pseudodendrite. And in the picture on the right, you have a very classical picture of a filamentous fungal keratitis. If we look at the edges, it is anything but round. They are feathery edges, and the surface looks dry and it is raised. So feathery edges, dry and raised surface are all indicative of filamentous fungal infection. Then you can have immune rings And you can have satellite lesions and hypopyon. These hypopyons are not sterile because they do contain fungal filaments. And if you look at the picture on the down left, there's a small infiltrate which is about 1 to 2 millimeters in size. But if you look at the lesion on the endothelium, there's a large plaque-like lesion or a stuck-on lesion, which is termed an endoexudate or an endothelial plaque, again, which is suggestive of a fungal keratitis. And you can have pigmentation as well. So here's another picture of pigmented fungal keratitis, that is dermatiaceous fungal keratitis. And you can also have a collar button configuration, and this collar button configuration is suggestive of yeast infection or a candidal infection. Coming to the limitations of clinical evaluation, so this was one study published in the AJO where experienced cornea specialists could say whether the ulcer was bacterial, fungal, or amoebic based on the clinical findings only in 73% of the cases. And they could predict the presence or absence of microbial recovery in 76% of the cases. So in all other cases, even they were prone to not diagnosing properly or missing a diagnosis. So they could not be 100% sure. And also, prior antimicrobial use hampers clinical diagnosis and microbial recovery for obvious reasons. And another study said that serrated margins, raised infiltrate, and color other than yellow each were independently associated with fungal keratitis. So if one among the three is present, there's a 63% chance that it's a fungal keratitis. Whereas if all the three are present, it gives us an 83% chance that it's a fungal keratitis. So coming to the management, as we know, corneal scraping and microbiology form the backbone of management of any infectious keratitis. And as we know, the scrapings need to be performed from the base and the edge of the ulcer using Kimura spatula. And the one important point when we scrape a fungal keratitis is that you can feel a grating sensation, whereas when you scrape a bacterial ulcer, it would seem like you are scraping butter. So it will feel much softer. And the basic stains that are used are at least gram stain, KOH mount, blood agar, and Saborod's dextrose agar or PDA wherever they are available, or at least a single KOH mount needs to be performed. We also need to do a syringing to rule out any sac infection, and we also should monitor the blood sugar levels. So this is a picture showing scraping from the base and the edges and plating on blood agar and smearing on slides. So there are a lot of staining methods, but 10% KOH is the single most important, simple and sensitive staining method which can be performed regularly in any clinic. So it has a high sensitivity. There are various other stains like grams and calcofluor white, etc. And calcofluor white and acridine orange stain would also require fluorescent microscopy. And if you see the picture on the top left, you have filamentous fungi. Here you have pigmented filamentous fungi. And here there's a picture showing both nocardia and septate filamentous fungi. And here you have yeast with budding round cells. These are all pictures of KOH mounts. And even gram stain can pick up filamentous fungi. This is a picture showing fluorescent microscopy and filamentous fungi. Then again, GMS stain is supposed to be the best for histopathological examination, and acridine orange stain showing filamentous fungi, which would require fluorescent microscopy. Then Saborod's dextrose agar or potato dextrose agar is the plating method of choice in case of fungi, and this should not contain cyclohexamide as it inhibits the growth of certain saprophytic fungi. Also, most of the fungi grow on blood agar, so in cases PDA is unavailable, you can culture on blood agar followed by subculture on PDA if necessary, and species identification is based on the microscopic and the macroscopic features of the colony. So here you have pictures. On the top you have fusarium growth, and here there is a colony of aspergillus, and here there is candidal colony. So how do you diagnose a fungal keratitis definitively? That is, either fungal elements should be present on smears, or fungus should grow on more than one medium in the absence of fungi on smears. Fungus, if it grows on a single medium and if there is fungus on smear, or there should be a confluent growth on a single medium at the site of inoculation in the absence of a fungus on smear. So 83% of the growth occurs in 3 days and 97% in 1 week. So we need to incubate for a period of 1 week before labeling a culture as negative for fungus. So there are other modalities as elucidated by Lalita ma'am. That PCR is particularly useful in culture negative cases, and it's highly sensitive. It is 74% sensitive, and most of the results come within 4 hours. Confocal microscopy and corneal biopsy can be used in deeper lesions where the access to the material becomes difficult. Corneal biopsy can also aid as a therapeutic modality because you are debulking the ulcer. Then this picture is from a study published from Aravind, which looked at Aspergillus versus Fusarium on confocal microscopy. And they said, although IBCM remains a valuable tool to detect fungal filaments in fungal keratitis, it cannot really distinguish between a Fusarium and an Aspergillus species because both of them might look very similar. Coming to the medical management, as we know, natamycin 5% is the drug of choice for filamentous fungal infection, which is the most common fungal infection for us. And the mechanism is that it binds to ergosterol and prevents the influx of amino acids and glucose. And you can add voriconazole 1% if it's worsening or severe. Similarly, amphotericin B is a drug of choice for yeast infection. This binds to ergosterol and causes the formation of ion channels. And medical therapy can be continued for 3 to 4 weeks before going for a surgical management depending upon the clinical state. Then here are the indications for systemic therapy: large ulcers, deep ulcers, scleral involvement, post-PKP cases, endophthalmitis, impending of frank perforation, and tunnel infiltrates which are unresponsive to topical medication. In all these cases, we can go for systemic therapy. These are all the drugs that are used systemically. And one thing we need to remember is that we have to monitor the liver function test because the mycotic ulcer treatment trial has shown that there was a significant increase in the liver aspartate and alanine transaminase levels when the patients were started on oral voriconazole. Not only that, most of them experienced visual hallucinations as well. So these should be kept in mind. There are other drugs which are being used of late. There are reports here and there, echinocandin derivatives, that is caspofungin and micafungin. They inhibit the D-glucan synthesis in the cell wall, and they are active against Aspergillus and Candida. And here comes the TST protocol, which has been put forth by Dr. Namrata Sharma and all from RP Center. For any fungal keratitis, there's a TST, that is a topical, systemic, and a targeted therapy which can be used. So for small ulcers which are less than 5 millimeters in size and are less than 50% in depth, topical natamycin has to be started. And you should look for the response for 7 to 10 days. And if it's responding well and good, continue the same treatment. And if it isn't responding, you can add either topical vozole or amphotericin B. And in cases where this ulcer is very severe, that is, you have a large ulcer or it's very deep, in addition to the topical natamycin, you can straight away start off a systemic therapy as well, in addition to the indications which we had seen in our previous slide. So that is what they've advocated. So these systemic antifungals can be used. You also have to monitor the liver function test. And in case it is not responding, you add again topical voriconazole. And in case this also is not responding to topical vozole, then you go for the targeted therapy wherein you use intracameral or intrastromal drugs. So wherever there's a hypopion, you can use both intracameral and intrastromal antifungal. And where there's no hypopion, you can use only intrastromal drugs. And these can be repeated for 3 to 4 times, 3 days apart. That is the intrastromal and intracameral injections. And if it is not responding, ultimately, you're going for a therapeutic penetrating keratoplasty. So coming to the indications of intracameral injections in non-responsive cases, as I said, and thick hypopions and endothelial and deep AC exudates, these are the dosages of amphotericin B and vozole. Then for intrastromal injections, again, deep keratitis and keratitis which does not have perforation and those which are not responsive to topical and systemic antifungals, as we saw, you can use intrastromal voriconazole. I will not be going into the details of the surgical management, but just to mention a few, you can do corneal debridement. Biopsy, as I said, is again both diagnostic and therapeutic. Amniotic membrane transplantation and conjunctival flaps, glues with BCL in cases of perforated or impending perforations, then therapeutic penetrating keratoplasties can be done. And collagen cross-linking role is also being assessed of late. Coming to the major landmark trials, firstly, mycotic ulcer treatment trial. So this was for smear positive filamentous fungal keratitis, and this was natamycin versus vozole, topical natamycin versus topical vozole. And they saw that natamycin had a better 3-month visual acuity. Natamycin group were less likely to have perforation, and fusarium cases fared better with natamycin than with voriconazole. So vozole should not be used as a monotherapy in filamentous fungal keratitis. That is the main conclusion, and that natamycin is the drug of choice. Coming to mycotic ulcer treatment trial 2, this looked at the role of oral voriconazole in addition to the topical natamycin. So both the arms received topical natamycin. One arm received oral voriconazole, whereas the other arm received oral placebo medication. And here also they found no difference in the rate of corneal perforation or the need for TPK in both groups. And finally, they said that there is no additional benefit of mycotic oral voriconazole in case of filamentous fungal keratitis. But when they did a sub-analysis of fusarium cases, they said they may benefit from the addition of oral voriconazole. Coming to cross-linking assisted infection reduction, I think this study was published by Madhu sir and all. So in deep recalcitrant stromal fungal keratitis, they randomized the patients into the cross-linking group and non-cross-linking group. And in the cross-linking group, most of the cases experienced perforations, and hence the trial was stopped. And thus they proved that cross-linking did not improve outcomes in deep recalcitrant stromal fungal keratitis. Then lastly, this is a recent publication assessing the cross-linking effect, a randomized clinical trial evaluating the effect of adjuvant cross-linking on outcome in fungal keratitis. So they said that there was a 1.32-fold increase out of culture positivity in the group that received cross-linking. Similarly, there was no difference in the 24-hour culture positivity between amphotericin B and natamycin. So this compared cross-linking versus no cross-linking and amphotericin B versus topical natamycin. So there were two things that were being compared. So they did not find any difference between topical amphotericin B outcomes and topical natamycin outcomes. But the best corrected visual acuity was worse at 3 weeks and 3 months in the cross-linking group. Similarly, they had an increased odd of culture positivity at 24 hours. And there was no infiltrate, there was no difference in the infiltrate or scar size or adverse events when comparing cross-linking to no cross-linking. Hence, they concluded that there is no benefit of adjuvant cross-linking in case of fungal keratitis. So that was it. Thank you for your patient listening.
Thank you, Ramya, for beautifully covering all the aspects of fungal keratitis. I think, Raghava, you can start sharing your screen. And for those of you who don't know, Ramya Setumraju was the winner of the best paper of the conference last year for her excellent work in eye banking, especially storage medium.
Thank you. Thank you, sir.
Thank you, Ramya. Raghava, you can unmute yourself and Raghava,
yeah. Am I audible?
Now you are audible, Raghava. Please go ahead.
Yeah, 1 minute. Yeah, good evening once again, and thank you VOA and APOS for giving me this opportunity. Good evening all. So today I'm going to present about HSV keratitis. So as first Dr. Nasrin covered bacterial keratitis and then Dr. Ramya covered fungal keratitis. We are coming in the order of the commonest organisms causing microbial keratitis. First is bacterial, then fungal, and then viral. So out of the viral, HSV is commonest. So the diagnosis of HSV is mostly clinical. So I'm going to describe about clinical manifestations of HSV keratitis. So I will take you through a case where we can see maximum manifestations of HSV keratitis so that it will be easy to remember. So this is a case of HSV keratitis where he presented with pain, redness, discharge in the left eye. Right. So in this image, you can see scarring, edema, and here. So conjunctival congestion is seen, scars seen, and then two dendritic lesions. So if you closely see those dendritic lesions, so what is your diagnosis? It's a dendritic epithelial keratitis, HSV epithelial keratitis. So coming to the various epithelial manifestations of HSV. So first is the vesicular form, and then dendritic form, and then geographic, metaherpetic, and then marginal. So first is a vesicular form, where classical features of vesicle form is it will not take the stain, and you have to differentiate it from microsporidial, adenoviral, and thygissons, etc. So the next one is the if vesicular form fused to form dendritic. what are the characteristic features of dendritic form? These are raised lesions with a linear branching pattern with large terminal bulbs, and also with swollen epithelial borders. So HSV epithelial dendritic keratitis should be differentiated from the pseudodendrite. As Ramya pointed out that fungal keratitis also can mimic this dendrite. So what is a pseudodendrite? So here the elevated it will not take up the stain, or it will take very minimal stain, and the margins are not elevated and not rounded. So and there is no bulbous aspect in this. So we can see this in a healing epithelial defect, or in a fungal keratitis, or amoebic infections, or drug deposits. So multiple dendrites in a single in an eye can be seen in a case of allergy like atopy or an immune suppression. So next one is HSV geographic keratitis, another form of epithelial keratitis. So characteristic feature of geographic keratitis is that dendritic lesion will enlarge to form geographic pattern. So if you give steroids in a case of dendritic form, it can lead to geographic form. So what is the differential diagnosis for this geographic pattern? Geographic, whenever you say geographic ulcer, you have to differentiate it from the metaherpetic or neurotrophic ulcer. So what differences between these two are, if you see closely the margins in a case of geographic ulcer are irregular and they are scalloped. Whereas in a case of neurotrophic or metaherpetic ulcer, you can see the eye is minimally inflamed and usually occurs in the interpalpebral area. Usually they are round or oval in shape, and epithelium is elevated and smooth, edges are thick and rolled. Because management is entirely different between these two, geographic and neurotrophic ulcer. So you have to identify what is it. So next, another form of epithelial keratitis is marginal keratitis. Here, HSV marginal keratitis usually occurs close to the limbus, and you can see vascularization, and there is no lucid interval. You have to differentiate it from staphylococcal marginal keratitis. This is staphylococcal marginal keratitis. If you classically see the staphylococcal marginal keratitis, usually will not take up the stain. There will be no epithelial defect, and there will be lucid interval between the lesion, and usually there will be no vascularization. So these are the differences between HSV marginal keratitis and staphylococcal marginal keratitis. So I actually kept this presentation for the PGs, but PGs cannot ask questions in that. So I kept 5 questions at the end of the presentation. So if you go through this presentation, you should you answer those questions, right? So HSV marginal keratitis is caused by active virus, whereas staphylococcal marginal keratitis is an inflammatory response. And epithelial defect will be there in HSV marginal keratitis, and vascularization is seen. And main important thing is HSV marginal keratitis progress towards the center, whereas staphylococcal marginal keratitis progress circumferentially. HSV marginal keratitis is not associated with blepharitis, whereas staphylococcal marginal keratitis is associated with blepharitis. HSV marginal keratitis can occur in any meridian, whereas staphylococcal marginal keratitis usually occurs at 2, 4, 8, and 10 o'clock, where limbus is crossed by the lid margin. So coming to our case, this is a HSV dendritic keratitis. So so we covered almost epithelial manifestations like vesicle form, dendritic form, geographic form, and then marginal keratitis and neurotrophic keratitis. So all these are epithelial manifestations of HSV keratitis. HSV keratitis diagnosis will depend on the layer of the cornea which is involved. So we covered epithelial manifestations. So next, coming to the stromal manifestations. If you see our case, we can see stromal edema and then a scar. So mainly coming to the stromal manifestations, there are two manifestations like HSV stromal immune keratitis, HSV stromal necrotizing keratitis. How to diagnose these things? So before going to this, you have to remember 3 clinical clues like history of recurrences. In a case of HSV keratitis, usually there will be a recurrence. So you have to take that into account. Whereas in a case of bacterial or fungal, usually there will be no recurrence. So there will be any history of trauma will be there, some other thing, but there will be no history of recurrence. history of recurrence classically gives a clue towards HSV. So how to differentiate between these two stromal manifestations? So there will be no epidefect in a case of immune stromal keratitis. Whereas a HSV necrotizing stromal keratitis, there will be an epidefect. Epidefect with the stromal infiltration is an HSV necrotizing stromal keratitis. HSV stromal keratitis without an epidefect is immune stromal keratitis. Right? We'll go through those two. So HSV immune stromal keratitis usually presents with the cellular reactions in the stroma. It can be a diffuse, focal, or multifocal. It can present in the central or paracentral area. So we know what is immune ring, name of the immune ring which we see in HSV stromal keratitis is Wesley ring. It's a sterile infiltrate. It can be complete or incomplete, single or multiple. It's a type 3 hypersensitivity ring. Again, HSV immune stromal keratitis is we will not see epithelial defect, but stromal cellularity will be seen. Again, I am pointing out stromal cellularity because HSV stromal immune keratitis should be differentiated again from endothelial keratitis, where you will not see stromal cellularity, where you usually see more of edema. Right. So coming to the another form of stromal keratitis of HSV, that is HSV necrotizing stromal keratitis, where here epithelial defect will be there, stromal infiltration will be there. There will be a collagenolysis, stromal melting, and then it can lead to perforation if not treated aggressively. Again, history of recurrences, deep vessels. Again, deep vessels also will give a clue, and bold scars. So history of recurrences, deep vessels, and bold scars, these three are very important in diagnosing HSV keratitis. Right. So usually they can be associated with geographic epidefect and epithelial defect, usually not overlying the infiltrate. So whereas in a fungal or bacterial, usually epidefect and infiltrate will coincide. Whereas in a case of HSV necrotizing stromal keratitis, epithelial defect may not exactly overlay the infiltrate. So if there is a HSV necrotizing stromal keratitis, it can have a secondary infections, and that then you have to see for yellowish appearance of the infiltrate and density and all. Again, coming back to our case, first in the first picture we've seen epithelial dendritic keratitis, and then he has stromal immune keratitis. So HSV epithelial dendritic keratitis and stromal immune keratitis. Again, in the same case, if you see closely, he has a fresh and old capes and few cells. So again, so what is the diagnosis? And with posterior synechiae. So again, HSV, when you are diagnosing HSV uveitis or HSV uveitis, posterior synechiae also give a important clue. So what are the different endothelial manifestations? So again, like we covered HSV epithelial keratitis, HSV stromal keratitis, again now endothelial keratitis. Endothelial keratitis, common forms are disciform keratitis and diffuse keratitis. Linear form is not at all a common, even I have not seen that. So coming back to HSV endothelitis. So here HSV endothelitis, you will see only edema mainly, not cellularity. If you see cellularity, it will go into the HSV stromal immune keratitis. Whereas if you see edema, that means underlying endothelium is affected. Usually you will see capes on the endothelium underneath the edema, DM folds. And endothelitis can be associated with increased IOP because may be associated with trabeculitis. This is a focal, again, HSV disciform endothelitis. So here inflammatory reaction within the endothelium. There will be secondary stromal edema. So HSV diffuse endothelitis. Again, how to differentiate between the HSV disciform endothelitis and stromal immune keratitis is stromal immune keratitis will have an infiltrate, whereas disciform endothelitis will not have infiltrate. So coming back to diffuse endothelitis. So here you will have increased IOP, diffuse pigments on the endothelium, DM folds. Sometimes it can be associated with AC inflammation like hypopyon also. So again, increased IOP also gives a clue. So how to differentiate between this HSV endothelitis and normal uveitis? So in normal uveitis, you will not see these DM folds or not DM folds, but not diffuse pigments. Diffuse pigments on endothelium will be seen in two cases. One is Fuchs, another is HSV endothelitis. Whereas in a case of normal uveitis, you will see pigments in the Alts triangle. There will be an inferior Alts triangle, not on the diffuse endothelium. Right. Diffuse capes and severe anterior chamber reaction will be seen, and segmental iris atrophy also can be seen. So IOP is associated with trabeculitis, right? So the same patient is diagnosed as HSV epithelial keratitis with HSV stromal immune keratitis with HSV diffuse endothelitis with HSV iridocyclitis. So HSV, why it is important is because it can affect one layer and then immediately it can affect another layer. It can go from one form to another form. It can present with different forms. So coming back to HSV treatment protocols. So this is like wherever there is an active viral infection, antivirals play a role. Whereas in a case of inflammation, steroids play a role. So these two we have to remember, whether it is an infective process or inflammatory process. If you keep this in mind, HSV treatment will be very easy. In a case of HSV epithelial keratitis, we can treat like HSV epithelial keratitis again, vesicle form, dendritic form, geographic form, marginal keratitis, everything. So we can treat with acyclovir ointment or tablets, systemic or topical. So only epithelial keratitis where we can consider steroids is marginal keratitis because there will be some inflammatory pathology. So we will use steroids along with antivirals. Remaining epithelial keratitis, you should strictly avoid steroids. Whereas in a case of stroma, coming back to stroma again, stromal immune and stromal necrotizing. In a case of stromal immune keratitis, as name suggests, it's an immunological process. So you have to give main treatment here is steroids. Here we give antivirals as a prophylactic to prevent secondary recurrences. In a case of HSV necrotizing stromal keratitis, again here pathology is both infective and inflammatory. So we have to give antivirals along with steroids. Whereas in a case of endothelial keratitis, again infective and inflammatory, so we will give antiviral and steroids. So here usually endothelitis form, we will give systemic antivirals. The treatment dosage is tab acyclovir 400 mg 5 times per day. If you want to prevent recurrences, like head study was proven, like in immune stromal keratitis, to prevent recurrences, we will give prophylactic dosage. That is tab acyclovir 400 mg 2 times per day. So one important point is HSV can affect all corneal layers. So before closing this, as I told you, I kept 5 questions. So what is this? This is mainly for PGs. So if you go through the presentation, again, what is the diagnosis of this? Here multiple ulcers are there in the periphery and spreading circumferentially. And the next question is, here ulcer is there with vascularization. This is the third question. This is the fourth question, where you can see infiltration with edema in the stroma without epidefect. Again, what is the diagnosis? Here, as it was already covered, that DM folds are there with pigments on endothelium. Right. If you could answer this would be good.
Thank you, Ram. Thank you very much for that case-based discussion, layer-wise. It was very useful. I think Dr. Padmini ma'am, you can start sharing your screen.
Yeah. Dr. Raghava, at the end, you can highlight on long-term antiviral, oral antiviral to prevent recurrent corneal lesions.
Yeah. Should I tell now?
For the private practitioner's sake.
Yeah. Long-term oral.
At the end, we can discuss. I think Dr. Padmini will start.
Yeah.
Okay. I think Padmini madam can start her present. Padmini madam from Vishaka Hospital. Madam, did you unmute yourself? We are not able to hear you. Ma'am, Padni ma'am. We are not able to hear your voice, madam.
Hello, can you hear me now, ma'am?
Yeah, now it is better, ma'am. Please go ahead. Yeah.
It is not moving. Okay, good evening, one and all. After an extensive discussion on common microbial organisms, let us have a brief discussion about the atypical corneal presentations. So why do we call them an atypical corneal ulcer? It is because of the delay in the diagnosis. Mainly it is because of the lack of familiarity with the organism and also because of the non-specific clinical picture they present. Most of the cases have the duration is chronic and they are refractory to the conventional medical therapy. So some of the atypical corneal ulcers are nocardia keratitis, moraxella keratitis, mycobacterial keratitis, acanthamoeba keratitis, pythium keratitis, and microsporidial keratitis. Let us discuss them in detail. So coming to nocardia keratitis, nocardia is a gram variable aerobic branching beaded filamentous, which is weakly acid-fast bacteria. It has a variable response to most of the first-line medications that are used for bacterial keratitis, that is fluoroquinolones. And the most common species are Nocardia astroides and Nocardia arthritis. Here in this picture, you can see the beaded filamentous Nocardia. The risk factors are trauma is the most important risk factor for Nocardia keratitis. Any ocular exposure to soil or plant matter can also cause Nocardia, or prior ocular surgery or use of topical corticosteroids or even contact lens is associated with Nocardia keratitis. So most commonly, Nocardia is prevalent in the soil of South Asia. So study by Lalita Prajna and al. Have shown that Nocardia was isolated from 8.3% of the samples of bacterial keratitis. Clinically, it presents as a patchy anterior stromal infiltrate in a wreath pattern with satellite lesions. It may also present as a non-specific punctate epitheliopathy. And sometimes we can see the ulcer is studded with yellow pinhead size infiltrates. Usually, if we see the ulcer presence in the mid-periphery of the cornea. So to note, we have to remember this clinical picture because atypical corneal presentations, we have spoken that they have an atypical presentation. So this presentation is usually seen when the nocardia keratitis presents within 2 weeks of onset of symptoms. Coming to the diagnostic features, it can be diagnosed by various normal routine scraping or culture, where gram stain will identify them as positive beaded branching filamentous organism. Acid-fast stain, 1% acid-fast stain will identify the nocardia filaments. Coming to the culture, blood agar and chocolate agar will show dry, tiny, chalky white colonies which grow in a period of 48 to 72 hours. Even confocal microscopy is useful in identification of nocardia keratitis, especially in deep-seated infiltrates where routine microbiology workup does not yield any positive result. So you can identify the nocardia filaments as hyperreflective, which are much thinner when compared to that of the fungal hyphae. Study by M.S. Sridhar and et al. Have shown that, and even several other studies have highlighted that amikacin is the drug of choice because most of the nocardia isolates are sensitive to amikacin, drug amikacin. So this is one study which has highlighted the species, drug sensitivity and clinical correlation, where they have said that those who present within 15 days of onset of symptoms present with the typical clinical features which I have spoken, that is a ring infiltrate with a wreath pattern, and all the species will have a 100% sensitivity to amikacin. This study also highlighted that most of them who present within 15 days of onset have higher recovery rate. So the treatment for nocardia is amikacin, that is 2 to 2.5% remains the first line treatment for nocardia keratitis. The other drugs that can be used are tobramycin, gentamicin, imipenem, or moxifloxacin. Topical corticosteroids should be avoided as highlighted by Dr. Nazreen ma'am as a part of a SCUT study. Coming to the other organism, that is acanthamoeba. Acanthamoeba is a free-living protozoan which belongs to the genus Acanthamoeba. The most common species are Acanthamoeba, castellani, and polyphagia. It presents as a trophozoite and a cystic form. The trophozoite form mainly consists of the central nucleoli, which is a prominent one, and surrounded by contracting vacuoles and pseudohyphae. Whereas the cystic form is a double-walled cyst which is polygonal or star-shaped. So epidemiology, as already spoken by Lalita ma'am, the acanthamoeba keratitis in India, the percentage varies from 1 to 3% in various published data. Acanthamoeba keratitis should be considered in all contact lens wearers and also in non-contact lens wearers where there is an exposure with soil or contaminated water. So when the trophozoite binds to the glycoprotein of the epithelium, corneal epithelium, causes destruction of the epithelium, and further it penetrates into the stroma, there is a release of several proteases, especially the serine and the cysteine protease, which cause stromal destruction. It also has a tendency to surround the corneal nerves, hence causing radial keratoneuritis. Tu and et al. Have established 5 levels of acanthamoeba keratitis based on the slit lamp biomicroscopic findings. They are epithelitis, followed by epithelitis with radial neuritis, and then anterior stromal disease, followed by deep stromal keratitis and ring infiltrate. So this clinical picture shows that of the epithelitis form of acanthamoeba and that of the ring infiltrate and perineural infiltrates. So as we see, in the early stage, acanthamoeba keratitis can be confused with that of herpes simplex keratitis, whereas the advanced stage resembles that of a fungal keratitis. So these acanthamoeba keratitis should be kept in mind when any ulcer is not responding to the normal topical antifungals. And this study, that is Lorenzo, Morel and et al. Have shown that perineural infiltrates are highly suggestive for acanthamoeba keratitis, and they have been reported in up to 63% of the cases at 6 weeks. As we all know, the characteristic ring infiltrate, which we all speak in acanthamoeba, is only seen in 50% of the cases. The other diagnostic modalities for identifying acanthamoeba are mainly confocal microscopy, where in vivo, it is a non-invasive tool which can help us in diagnosis of acanthamoeba. It can identify the double-walled hexagonal hyperreflective structures, that is a cyst, which is 10 to 25 millimeters in diameter. PCR also has a higher sensitivity for identifying the acanthamoeba cyst, which can give the result within 60 minutes. So the routine scraping methods can be used when there is a severe ulcer with a multiple number of acanthamoeba cysts. They can identify the cyst easily. That is the 10% KOH will identify the oval shaped cyst. The other staining methods are GIMSA stain, periodic acid sieve stain, hematoxylin and eosin, calcofluor white and acridine orange can also identify the cystic form of acanthamoeba. Acanthamoeba is best cultured on non-nutrient agar, which is overlaid with E. coli. So you can see the characteristic trails that form as a trophocyte moves across the plate. So the treatment of acanthamoeba is controversial because of the varied clinical picture it presents and also the varied response it has to several antimicrobial drugs. The most commonly used drugs are the bigonides, that is polyhexamethyl bigonide at a concentration of 0.202% or chlorhexidine. They can be used as an isolated drug or can be combined with diamidines, that is propamidine isothianate at a concentration of 0.1%. So these bigonides and diamidine act at the cell membrane level, causing damage to the cell membrane. The other drugs that are being tried are the voriconazole and miltefosine. So as we all know that antimicrobials mainly act against the pathogenic amoeba, but they're not fully effective for the both stages of acanthamoeba. So these drugs, as we all know, they're not available as ophthalmic preparations and they're toxic to the ocular surface and they're required for a longer term treatment, that is up to a period of 6 months. So this was one study from Peru, which has highlighted that voriconazole can be given as a first-line treatment for acanthamoeba keratitis, saying that the voriconazole as a triazole can inhibit ergosterol biosynthesis, as ergosterol is a main component of cell membrane of acanthamoeba. The other study by Bhupesh Bagga and et al. Have highlighted the use of topical miltefosine in patients with acanthamoeba, but this is only a pilot study where they have concluded that it cannot be used as a primary treatment, but it can be combined with other drugs for a better effect. So the role of steroids also remains as a controversy in acanthamoeba. It was only indicated when there is persisting inflammation, such as in anterior scleritis, or when the patient presents with severe pain or it is an indolent ulcer, and it can be started only after 2 weeks of initiation of anti-acanthamoeba therapy. So because of the long-term treatment, it is associated with several complications. We can see broad-based anterior synechiae, secondary glaucoma, iris atrophy, mature cataract, and persistent endothelial defect. And sometimes it can land up in uveitis and scleritis. Coming to the third uncommon atypical presentation is the pythium keratitis. So pythium inseriosum is an oomycete with a zygomystous fungal-like features. which presents as a broadly branched, sparsely septate or aseptate with ribbon-like folds. Though it looks like a fungus and microbiologically looks like fungus, but does not respond like fungus. And why? It is the Mendoz and et al. Have shown the clinical cell membrane characteristics of Pythium insidiosum. We can see that the cell wall of Pythium contains cellulose, which is not present in that of fungus, and there is no ergosterol in the cell membrane of Pythium. So it is because of the lackage of this ergosterol that the Pythium does not respond to the common antifungals. Clinically, it can present as a dense grayish-white infiltrate, or it can present as a reticular pattern or peripheral expanding tentacles with pinhead shape surrounding infiltrates and a peripheral gutter. So these are some of the clinical pictures which show the tentacle-like extensions, taut infiltrates, and a peripheral gutter and a reticular pattern. So high clinical suspicion is required before we subject them to microbiological and histopathological examination. So microbiology under 10% KOH, you can see the sparsely septate hyphae of the Pythium with numerous vesicles within it, whereas that of the fungi are with numerous septae. The other which is a clinching diagnosis for Pythium is the ribbon-shaped folds, which can be seen under fluorescein microscopy. And on culture, on 5% sheep blood agar, Pythium grows as a flat, feathery-edged, partially submerged, colorless or light brown colonies with filiform margins. So the mean duration of growth is around 3 to 5 days. The main diagnosis lies in identification of zoospore in liquid culture. So it takes around 2 days after the fungus that has been grown on blood agar. So as we all seen that it is so tedious process to identify the Pythium, the newer staining technique which has been described by Mittal and et al. Have shown that potassium iodide sulfuric acid can identify within 2 hours of securing the specimen. So when this potassium iodide combines with the cellulose of the Pythium, it forms an intermediate complex, and iodine causes the Pythium to stain as blue, whereas that of fungal keratitis stain yellowish brown. There is also a role for confocal microscopy to identify Pythium keratitis. They appear as hyperreflective branching structures with a mean branching of 78.5 degrees. And if you see them, if you differentiate them from fungal keratitis, these are thin filamentous lines, whereas that of the fungi are broad, much hyperreflective and broader. So as we all have seen that the major component is the cellulose. So antibacterials, mainly those which inhibit protein synthesis, are efficacious against Pythium keratitis, mainly macrolides, tetracyclines, and linezolid. Loreto and et al. Have, in their major study, have found that azithromycin and clarithromycin have the lowest MIC. This is another study that is done, that is Bhupesh Bagga and et al. Have shown that the maximum zone of inhibition is for linezolid and minimum MIC for tigecycline. But if we see, we have been using azithromycin because of its easy availability and less toxicity. So some of the successful studies are by Bhupesh Bagga and et al. We have shown topical linezolid of 0.2% along with topical azithromycin 1%, either eye drops or ointment with oral azithromycin works better for Pythium keratitis. The other study by Sayana and Saili recently published have shown that along with, instead of oral azithromycin, oral linezolid also has shown better cure rates up to 80%. Coming to the other organism which is uncommon, that is Microsporidia. Microsporidia is an obligate spore-forming eukaryote which is very slow growing, causes an insidious infection, and it does not grow in any of the commonly used microbiological media. It has a double-walled cell membrane with a prominent nuclei and a polar tubule. The risk factors are similar, that is a trauma or contact lens wear or any contact with domestic animals. So clinically, it presents as either as epidemic, it presents as a keratoconjunctivitis or as a superficial to deep ulcer with surrounding edema. So it can be mistaken with that of the herpes stromal keratitis. Stains which can identify the spores of Microsporidia are 10% KOH with 0.1% chalcofluor white under fluorescein microscopy. You can find them as oval-shaped spores. Giemsa stain also can pick up the oval Microsporidia. When the tissue is subjected for histopathological examination, H&E, gram stain, and acid fast, that is 1%, can also pick up the microsporidial spores. And at acid fast stain, you can find them as pink oval-shaped bodies with a waistband. The other diagnostic modalities to identify the microsporidial spores are confocal microscopy, where you find them as hyperreflective spots. Under electron microscopy, you can find the presence of a polar tubule, and PCR-based assays can also identify the organism. So we have seen that there is no defined guidelines for treating ocular microsporidial infection. Some of the studies have used a combination therapy of PHMB and chlorhexidine. The others have tried albendazole, itraconazole, and propamidine isothianate. Even topical voriconazole has also been tried before subjecting them to keratoplasty. So the main modality of treatment for microsporidial is surgical treatment, that is penetrating keratoplasty. So to summarize, a high index of suspicion is always required, and these organisms should be kept in mind when we are subjecting them for microbiological studies. So these organisms need to be known very familiar, and early diagnosis is required to achieve a successful therapeutical outcome. Thank you.
Thank you so much, ma'am. It is very difficult to talk on uncommon organisms, and you have done it very beautifully. Now we have the best, we have kept the best talk for the last. We have the surgical management of infectious keratitis by Dr. Sunil Tangras, sir. Navneet, can you share the presentation?
Sure, sir. Yeah.
Yeah.
I can mute myself.
Navneet, are you playing it?
Good evening. I will be talking on the surgical options in infective keratitis. Now, surgical interventions are done for a variety of disorders, particularly infectious disorders, and one has to recognize and promptly manage such conditions. And these are a host of conditions where surgical intervention was needed, and you would have seen many of these examples. Now, the aim of the surgical options are mainly to restore structural integrity, to resolve the infection, and most important, we have to always remember, is to visually rehabilitate the patient as well. Before we actually go into penetrating keratoplasty, there are a host of ancillary procedures that we need to think of and do, which are equally important in the management or in the successful management of infectious keratitis. And these can go right from tasseraphy and unfortunately up to evisceration. And this is just to show you an example of a tasseraphy and an entropion correction. Now, surgical debridement is a very useful tool in our armamentarium, especially for non-perforated ulcers. This has both diagnostic as well as therapeutic value, and it's of particular importance in ulcers with pigmented fungi. Tissue adhesives is another very tool in our toolkit, and these can be used for either impending perforations or even for very small, maybe sub 2 mm perforations. Other procedures like the amniotic membrane transplant and conjunctival graft are also useful before we actually consider penetrating or lamellar procedures for infectious disorders. Now, the tissue adhesives that are available in the market are not exactly FDA approved for corneal use. However, you can have an offline use on it. And always either do it at the slit lamp or at the operating microscope. Make sure you have the surface is dry before you apply the tissue glue. Sometimes you will have to go into the chamber and put in some air, and just put just about enough tissue adhesive that is required. And conjunctival flaps, there is a resurgence of this technique during the COVID times. It can be either a full thickness flap like the Gunderson's flap, or it can be also limited conjunctival flaps, especially useful in peripheral ulcers. Important that you always need to remove the Tenon's capsule, as it is an elastic tissue and you should do epithelial debridement around the ulcer. And these are examples of, one is a neurotropic keratitis and one is a peripheral perforated ulcer where conjunctival flaps were done. And here you can see that one has to dissect the tenons and do some epithelial debridement before proceeding with a successful conjunctival hood. Now coming to the corneal transplants, there are various therapeutic options available here. Of importance are the patch grafts, the overlay grafts, the lamellar procedures, and finally the penetrating procedure as such. Now this is just an old graph in 2006, more than a decade ago, on 261 cases where my indications for transplant, the most important was infective keratitis. And a patch graft is very useful mainly for peripheral ulcers. It can also be useful for small central ulcers. It can be either a temporary procedure or a permanent procedure. Usually these grafts are for ulcers 5 millimeters or less, and try your best to avoid the visual axis. Not always possible. It is basically nothing but a lamellar graft. The visual rehabilitation, however, has to come by a secondary procedure of a full thickness graft later on. And these are some examples of patch graft where I have done for some for peripheral perforation, and that last one, that is the video on the bottom, is a patch graft done for a Hansen's disease patient who had a non-healing sterile defect. And as you know, in these cases, it is a full thickness graft is not a good idea. They never work. So here we opted for a patch graft and it worked beautifully. There are again some more examples of a patch graft just to show how useful it is, especially in that peripheral ulcer on your left. So rather than going for a really big large graft, in such a case you can do a peripheral patch graft and later do a full thickness procedure if required. The video on your right is actually showing a patch graft done for a recurrent terrorism and not for an infective etiology. The other sometimes used procedure is when you do not have very good tissue, you have an emergency, you can do a lamellar keratoplasty, and this is a good alternative to have in the event of an emergency. The disadvantage of this procedure is the poor visual acuity, and you cannot handle the exudates within the chamber. So, but the advantages is those of a lamellar procedure. And this is one case. You can do a deep lamellar keratoplasty in certain cases of infective keratitis, mainly with anterior 2/3 infections. And this is a DLK which I had done long ago. And as you can see, it went off very well. This was a prolonged non-healing ulcer. Decided not to do a full thickness procedure, went ahead with a deep lamellar keratoplasty, and that exudate you see within the chamber, within the area of interest, is actually within the anterior. It's an organized hypopium. It's within the anterior chamber and not within the cornea, as one may think. And sometimes I do this overlay graft. This is with very bad peripheral ulcers. If I don't have a good cornea, I just take a button with the descemes membrane and suture it completely over it, and this works magically. It works. And this is a case where I have done for a perforated Murin's ulcer actually, and I extended this procedure to a few other cases with very, very bad peripheral perforations where doing a full thickness procedure was not feasible for whatever reason. And finally, when you come to the mother of all procedures in infective keratitis, that is the penetrating keratoplasty, one has to carefully assess and always know that this is the best option for vision. So always use good quality donor tissue. Do not use poor tissue, calling it a therapeutic procedure. And although the literature, they say the prognosis is poor, I can tell you most of these cases do very well. So that's a matter of debate, I suppose. But before you go on to keratoplasty, clinical judgment is very essential. The indications would include either perforated ulcer or an impending perforation, a large ulcer threatening the limbus where you don't want to go ahead and have the headache of doing a scleral, corneoscleral graft, or a non-healing ulcer. And these are some of the indications in keratitis. It's also a very old data done just on, it's in 2006, where most of the corneal transplants were actually done for perforated corneal ulcers. And what are the principles when you do a corneal transplant in such cases? Know very well these are very difficult procedures. So you may have to take a Fleringa ring, or you may have to take the support of superior inferior rectus. It's always a good idea to have suction trephines, especially for perforated ulcers where the globe is extremely soft. Centration is always problematic in these cases. Many of these cases need very large grafts. Sometimes they need eccentric grafts, and scleral suturing, etc. can cause bleeding. You have to appropriately size the donor cornea buttons, and very important, always avoid compression of the peripheral angle to avoid secondary glaucoma. And whenever you are doing on an infected area, remember this is nothing but an abscess. So use the same surgical principles that you would do in any abscess. Excise all the infected tissue, remove all the membranes and exudates from within the chamber, within the angle, over the lens, under the iris, wherever. You have to meticulously remove all these exudates. Try and visco-dissect or even mechanically dissect the angle to open it up. Ensure that the peripheral angle is formed, very important, and never ever handle the lens in an infective case. Usually you will use interrupted sutures in these cases. Also, when you form the anterior chamber in such cases, always form the anterior chamber with BSS. Preferably you can also use air, because this will push back the iris lens diaphragm and avoid damage to the lens, to the uvea. Try to handle the bleeding, try to handle any pupillary deficiencies, and always bury your knots. So these are some of the demonstrative cases that I have put up. So basically here just showing sometimes you have to do other procedures like peritomy, because your sutures would go there. Don't suture over the conjunctiva. You have to appropriately size your graft. Make sure that all the infective tissue is included within the excised button. Make sure that you remove all the debris, not only from within the chamber but from over the cornea before you actually trephine it out. I'm just showing in these cases how I have meticulously gone about removing these exudates. And in the next two cases, basically showing you the same procedures. Sometimes I use handheld trephines, sometimes I use suction trephines. And the next cases show just especially the case on the left shows that after excising the cornea, I saw a very bad, very advanced, advanced cataract, but whatever the temptation, no handling of the lens. It's very important, because if you remove that barrier, you are increasing the chances of endophthalmitis many fold. So do not handle the lens in such situations. And as you can see, in all my cases, I use very good tissue. And these are few of the other examples of perforation or impending perforation. And post-operatively, try and use specific antimicrobials, take a clinical judgment on steroids, manage complications appropriately, and try to avoid reinfection. Is pretty uncommon actually, not what the literature says. Secondary glaucoma can be quite common. Other problems like epithelial defects are common. Handle them as and when they occur. Regrafts, as you can see in my old data, regrafts, primary reinfection of the graft is extremely rare. And as you can see, hardly just 4% of the cases, and it's even less now. And of course, when you have to manage this, most of the time you need to do regrafts. Sometimes you have to go as far, if they don't work out, you have to go as far as a keratoprosthesis in some of these cases. That is long term. And the secondary glaucoma, you should be well versed in glaucoma procedures. You should be well versed in CTON procedures, just to show how much you need to do to actually successfully manage an infection over the cornea when you surgically interfere with it. In summary, less than 2 millimeters perforation or non-perforation, you can use either glue or amniotic membrane. If it is less than 5 millimeters, go ahead for a patch graft or an overlay graft. And more than 5 millimeters perforation, I think it is better to go ahead for penetrating keratoplasty. In very rare instances, you may get away with a lamellar keratoplasty. Thank you so much for watching this extensive presentation.
Thank you, sir, for that wonderful presentation and your excellent videos as always. Now I think I request Dr. Sujata Rao madam and Dr. Sriram Chandramurthy sir to start the panel discussion before we close the session for the next 10 minutes. Sujata ma'am and Sriram Chandramurthy sir. Gopal Raju sir.
Good evening, all of you.
Good evening, madam.
Yes, this was a comprehensive presentation, and we have covered all types of keratitis. It was really extensive, and it was the presentation was extremely good. So, shall we start with questions or?
We'll get the questions, ma'am. Meanwhile, if you want to add something to the discussion, please go ahead, madam. Navneet, if you have any questions, please post them to us.
Yes, sir. I'm just checking it.
Yeah. And Gopal Raju sir can also join us for the discussion for the next 10 minutes, and we'll close the this session after that.
Yeah, Sunil, what is the role of the lamellar surgery in the corneal ulcers? Where you will choose a lamellar surgery? What kind of an ulcer you choose? A full thickness surgery?
Yeah, basically I go for lamellar procedures mainly when you have peripheral ulcers which are perforated, and so doing a eccentric graft or very large graft on them, it's technically very it's not very great, and you can get a lot of complications. So it's better to do a staged procedure in these things. So you can get away with a patch graft. Initially, you save the eye. Yes, it's not the best option for vision, I agree, but you can always visually rehabilitate them later. So you give them a better chance than putting in a large graft. Handling a large graft, the post-op complications are just too much. Because when you do a very large graft, especially the secondary glaucoma is very difficult to handle. So if you want to make your headache less, it's better to do these lamellar procedures. The other place where I do lamellar procedures is if it's an emergency and I have very poor tissue. I never like to do a penetrating keratoplasty with a poor tissue. That's not at all a good idea. They never do well. This is my experience. So unfortunately, this labeling of, I've been fighting against this labeling of tissues as therapeutic and optical has to go. When you use a tissue like a penetrating keratoplasty, I think it's better to go for a very good tissue. Doesn't always happen, but it's better to use the best tissue.
Fungal again, a big no for the lamellar, no?
Yeah, so fungal, if it's a fungal keratitis, but having said that, if it's a fungal perforation, when you have to see whenever the ulcer perforates, actually most of your adherent glaucomas are what? They are basically perforated ulcers. So it is one of the natural forms of healing. So when it perforates and when you have the CMI coming there and healing that area, you can still get away with the lamellar keratoplasty. But active fungal keratitis, no, it's not a very good idea. Go ahead, do a full thickness penetrating keratoplasty, as I've emphasized. Try to take out all the exudates, all the membranes, everything, and form the very important, form the anterior chamber, form the peripheral angle. That's key. That's very much key to your keratoplasty doing well.
Sir, in large grafts, actually there is a technique where you can retain the peripheral 1.5 2 mm skirt.
Yes.
So that you don't distort the angle. Like it's if you have access to femtosecond laser, it's like the top hat configuration.
Yes, a mushroom keratoplasty or a top hat keratoplasty.
Where you can retain the angle, and then all the sequential problems with this secondary glaucomas can be managed. So that's a very valid point, sir. Yeah.
That you can do that, but remember, it is your suturing also, how tight you're suturing.
Yes.
That you can embarrass the angle with that itself.
Yes, and also the disparity between the donor and corneal, this thing. Anything
Exactly.
after 9, I think we have to maintain at least 1 mm difference.
1 mm, not less than 1 mm. You have to maintain that dome. Yeah.
Yes.
Raghav can highlight on the earlier, Anil has raised one question, the role of oral
prophylactic dosage of antiviral. Raghava?
Yeah. So usually give prophylactic dosage in patients who have multiple recurrences. So I usually follow 4-to-1 rule, like 4 episodes of epithelial keratitis or 2 episodes of stromal keratitis, or even 1 episode of uveitis or endotheliitis. I usually directly go ahead with prophylactic dosage of systemic acyclovir. So systemic acyclovir is one of the safest drug. So if we take every 3 months, ideally we have to do renal function test and check renal function test, and we can go ahead. And another thing is, when we do keratoplasty for these HSV scars or HSV keratitis, you have to keep on prophylactic dosage. And one more important thing for cataract surgeons is we have to keep them on prophylactic dosage after completing the case also. Until the patient is on topical steroids, I prefer to give prophylactic dosage of systemic antivirals in these cases.
Ramya, there is one question in the chat box. Ramya, there is one question in the chat box. What is the role of intrastromal
voriconazole?
Intrastromal voriconazole is not a first line of modality in cases where the topical medication is not helping, and in cases where the ulcer is very deep. So you have to go in, and if it's not responding to topical natamycin and voriconazole, you go ahead for an intrastromal injection.
Yeah. Personally related to this question, intrastromal voriconazole, we tried few cases, but we have not seen much benefit from intrastromal voriconazole. We tried after maximum medical therapy.
Intrastromal voriconazole, the main thing is it will not suffice with a single injection. You have to give repeated injections, at least 3 or 4 injections, and follow it up very closely. Dr. Rishi Swarup has a good experience with them, but as Raghava was telling, our experience, limited experience with this, we are not very happy, sir. Instead, we go for an early therapeutic graft.
There is one surgeon. Sorry, Gopal, go ahead.
In therapeutic grafts, when do you start steroids? Post-operative?
Oh, highly clinically, you have to judge that's based on your experience. But usually, I am worried about topical steroids. So that way you can wait. Suppose it's a fungal keratitis, you want a long period. But suppose you have an inflammation, which most of these people have, I do not think that systemic steroids is that much of a contraindication. So I go ahead and give systemic steroids. in many of these cases, because if you delay the steroids too long, you're going to get a host of other complications. Just thinking the infection is there. So, and then your graft is of actually no use. What have you done? It's an unnecessary surgical exercise. So you got to be judicious about this. You got to follow up the patient very carefully. Even if you start the steroids, you can always stop it if something happens.
Sir, we can try cyclosporin, sir. Cyclosporin and tacrolimus in the immediate post-operative period. And once you are confident that there is no recurrence of fungus, maybe that's again, as you told, clinical.
But
the problem with cyclosporin and tacrolimus, they are surface immunomodulators. So it's not going to be very helpful for whatever is going down there.
And also the effect for cyclosporin to occur will take time.
Yes. So these things, I mean, it's very good to have in your hand. Yes.
But tacrolimus also,
and all.
Tacrolimus
it's a surface modulator. They don't.
Tacrolimus has the double advantage of being an antifungal also.
Probably, maybe, but
instead of not having anything, at least till we start steroids, they can cover it up.
Yes. And just coming to the previous discussion where you were talking about your intrastromal voriconazole, I forget the doctor's name. There's one doctor from Agarwal who has published it in AAO, where he's used this impregnated.
Lionel Raj.
Lionel Raj. That's right. Thank you. He has used this impregnated Wattman's paper, number 44, I think.
Yes, sir. Yes.
He has shown excellent results, both in fungal keratitis and in. I personally do not have experience.
Fungal, he's using amphotericin B, sir.
Yeah, and he has shown very, very good response.
Yes.
There are, of course, other controversial treatments going around. Let's not discuss that. But but this is supposed to be very good.
Yes.
Sunil, for the postgraduates, you please highlight the importance of keeping the lens intact in the therapeutic grafts when doing the therapeutic graft.
Yes.
Prevent the spread of infection.
Yes. It's very important that you maintain this lens vitreous barrier, because if you look at any corneal ulcer, just think about it. You look at all your bad ulcers, your horrible ulcers, the vitreous never gets infected. Did you ever think about it? But if you do a cataract and any small thing and it goes damn into the vitreous and you are sitting with a real headache. If you actually think about it, why do corneal ulcers with such horrible infections, the vitreous never gets infected? And there were some surgeons who actually used to do evisceration for these patients, and they always took out very clear vitreous, which is horrible. So it is very imperative. Once you take out the lens during a keratoplasty, especially, there is no more barrier. So you can land up with a complete endophthalmitis. You can even go for a panophthalmitis. So it is always wise, as you saw in that video, even with hypermature cataracts, mature cataracts, I do not touch the lens.
Yes.
So, and I always do it as a secondary procedure, much better, much better.
And to avoid lens expulsion, sir, I think preoperatively mannitol.
Yes.
Maintain that hypotony intraoperatively. And if you still find a hard thing, sometimes I even go to the extent of doing a vitreous tap also.
But with an open eye, very difficult. The best procedure.
Not with open eye, sir. Preoperatively.
Yeah. Oh, preoperatively.
Preoperatively, if it's still hard with mannitol, I take out 0.1 cc of tap. It gives me 20 to 25 minutes of hypotonous eye to finish at least the first 8 or 12 sutures.
Yes, probably controversial, because when you do the tap, you're doing it on an infected eye. You may infect the vitreous with your tap, but that's different. But the problem with expulsive hemorrhage, you do not know who's prone to expulsive hemorrhage. So the one important thing that if at all I've seen 2 in the hands of my consultant, expulsive hemorrhages. It's a horrible situation because your whole eye is open.
Raghava, what is your experience in antivirals against the acyclovir and then the ganciclovir? Now, which one do you prefer as the first line?
So,
topical.
Related to this, actually,
HSV
there's no
keratitis.
much difference or much benefit with ganciclovir, so we are using only acyclovir right now. And also, we want to like keep it aside so that at least we can use if it is if it is not acyclovir is not working, then we can try this ganciclovir. But right now, we are using mostly acyclovir only.
Ointment from Raghava?
Ointment also acyclovir.
Okay.
No, in my experience, patients accept the ganciclovir much
Exactly.
better
I was
than
about to tell the same.
the acyclovir. Acyclovir little stings and then the
Stringent,
burning
not
will be
tolerant,
there.
sir.
Not tolerant.
Ganciclovir is more of a gel form. It is better tolerated.
Yeah.
Like
And also,
acyclovir
Raghava,
we give orally and ganciclovir in ointment forms.
and also, Raghava, when you are dealing with the HSV keratitis, some of the cases will come to you at the stage of the neurotrophic stage. So, in such incidences, the management is a little different. So, one should be keep
So
that in
yeah, neurotrophic ulcers, sir. Usually with torsorrhaphy, they will heal very nicely. They will heal very nicely with torsorrhaphy. So here torsorrhaphy plays a major role. It has advantage over BCL. So with anyhow, we'll give lubricants, intensive lubrication, and with torsorrhaphy, they will heal very nicely, sir.
Sorry, I went off for a minute. I don't know what happened.
Yeah, Dr. Raghava, how about recalcitrant viral dendrites in elderly patients?
So recalcitrant viral dendrites, actually I have not seen. Most of the dendrites, they resolve.
Sir, recalcitrants, you have to rule out diabetes and immunosuppression.
Yeah. Most of the dendrites, whether they will go into a geographic form or they will heal. I have not seen dendrite persisting there.
Let us say they are diabetic or immunosuppressants. Then how do you go about it?
Sir, if any dendrite is there for more than 2 weeks, you are probably looking at a pseudodendrite. We need to reassess the diagnosis.
Yeah. Another thing is severe toxicity also. So sometimes it will cause epithelial hypertrophy, and also it may mislead as a dendrite, and we keep on treating with acyclovir. So instead of that, you stop antiviral treatment, give lubricants in that case, and reassess after few days.
Medicamentosa.
Yeah.
Thank you.
So in the ulcers, when do you choose the cycloplegic? Which one to choose between the hometropine, cyclopentolate, and atropine for the practitioners and then the postgraduates? Anybody can share their experience. When to choose what type of cycloplegic?
Atropine works the best, sir.
Exactly.
So, but in small ulcers, if you give atropine, they may end up in longer rehabilitation. Sunil, you have any strategy or any protocol?
See, I always use, if the patient can tolerate, and if I'm not, as you said, small ulcers, I may go in for home atropine, but I always use either home atropine or atropine. That is the best cycloplegic. And this is always a trick question. Once, Ravi Thomas used to ask you, PGs, now you have a narrow angle glaucoma, you have a corneal ulcer, what do you give?
Yes.
You say pilocarp in there, he will tear you to shreds.
Yes.
So that's the thing. So this is always, these are the old things. So I think, yeah, with an ulcer, go ahead with atropine. Don't worry about the other things. You can always tell the patient your vision is going to get blurred for some time, but right now, it's needed.
My strategy is always, if the hypopion is more than 0.5, then I'll go for a atropine, nothing less than that, based upon the amount of hypopion. So if it is only trace or minimal hypopion, I'll go for a cyclopentolate. If there is no hypopion, only a hometropine. That's the general.
That's a good strategy.
Because atropine takes care of a lot of inflammation. So,
exactly.
And the pain is most important. No? That's what they complain about. You need to take care of the pain.
Yeah, when you tell me about pain, I think one important point in pain is in the acanthamoeba part, sir. Regular analgesics will not work here. I think we need to put them on amitriptyline or gabapentin for pain management. What is your experience, sir, with acanthamoeba?
Yeah. Yes, it is same. So, but pain in the fungal ulcers, especially, they'll notice the pain at the night time. I don't know why is the reason. What is the reason? But most of them then complain of severe pain at the night time before bed. So, still, I don't know the reason. But many patients, even in spite of an atropine and then Inox and then the severe analgesics, but still they complain of severe pain. That spike comes in the night. I don't know why.
This
As you were
also might
saying,
have a
acanthamoeba,
circadian rhythm, maybe.
in acanthamoeba, the pain is not only due to the uveitis, it's also due to the keratoneuritis.
Keratoneuritis, sometimes the scleral involvement, sir.
Yeah, scleral impulse. So that's why the pain is so much.
Pain is out of proportion. Out of proportion.
It's always, that is one of the hallmarks of acanthamoeba, isn't it?
Acanthamoeba
The
and,
symptoms are out of proportion to the signs.
Out of proportion, yes.
So that's the thing. So you will have to treat it symptomatically. The symptoms are more, you treat the symptoms more.
In our Indian scenario, the ulcers, most of the ulcers, non-healing ulcers, we need to do some of the investigation from the patient side. So most of them are middle or low socioeconomic. If you
All
go
of them.
on digging them, all of them, yes, you're right.
Yes.
And all of them are your area, most of them. So invariably they might have used already some home remedy or some
Yes.
The steroid from the outlet or something like that. They must have used some cocktail. So that could be one of the reason for the non-healing. So we literally have to spend some more time in eliciting such a history and then properly document it so that you are safe. And then at the same time, we can prepare the patient for the prognosis wise. This is my personal experience.
Oh yes, no, it's an experience everywhere, Gopal. This is the chronology of events. The first time he gets an injury with a vegetable matter, the first thing he does is put some dirty water into his eye. He washes his eye. Then he goes to the native practitioner who either puts his tongue or puts chicken blood or breast milk into his eye.
Yes.
Then he goes to the next practitioner who starts with steroids. And he actually, the pain, he feels better and it gets worse. And then he comes to us. So that's the natural course of events. And probably what the first talk was very useful, especially the last part, that Dr. Prajna emphasized. What about prevention?
Correct.
And that's where health education.
What is the end result to all the RMPs and things? And it was a very successful achievement.
Definitely.
I think in Nepal they did it.
Yes.
Sir, I think we have finished our time slot. I think we have our Honorable Secretary, Dr. Vishnuvardhan sir, with us. If he is there, if he can come on to the screen and give us the vote of thanks. Dr. Vishnu sir. Unmute yourself, sir. Yes, sir.
No, thank you very much. Actually, I'm relaxing and listening to your very good talk. Thank you all. Thank you all for conducting this very good session. Yeah, we missed our physical conference and we tried to make a big event as in a virtual platform. But as things went on, we had to compromise and do this free paper session and this ARC session. For the youngsters, my advice is use these APOS platforms. So that is very important for you because as a starter, you will get an opportunity here, which will be where you will get acquainted, and then you can go into the next stages. So APOS is trying to create platform for you, and most importantly, you open our APOS website every day, a few minutes, and see there are so many facilities we are trying to create. We are trying to create online membership application forms. We are trying to find a doctor appointments, case presentations, and so many other things are coming in the website. And if you use the website frequently, APOS will be encouraging to APOS to create so many other useful platforms in our website. Other thing is, okay, most likely we may be going to a physical conference in the next year, but most likely it is hybrid platforms. So APOS will be frequently conducting either CMEs through ARC or other things, where the most important thing is, even though when it's compared to international webinars and seminars, it's a small event, you will get the opportunity. That is our home turf. Use this home turf to jump into bigger league and bigger platforms. So use the APOS will try to create so many opportunities for all the young members. And I thank our scientific committee, Dr. Gopal Rajgaru, and all his team members, and all other participants, each and everybody by name. There are so many people who has done a lot of work for this event to be successful. I thank all of them, and I thank this micro team also for giving assisting us and helping us in this academic activity. And thank you all. Thank you.
Thank you, sir. Thank you so much. I think Microlabs team did a wonderful job from morning till now, almost hosting 60 free papers and a specialty session in the evening continuously throughout the day. So special thanks to Navneet and his team from Microlabs, Arshad, Datta, Ashok sir, Kumar, and everybody from the Micro-Vision team. Thank you so much. And I would like this to take this opportunity to inform all our APOS members that our society is shortly going to come out with our own journal, JOCR, Journal of Ophthalmic Clinics and Research. We are working on it, and probably by June, we are going to have the first issue. And I request all of you to start sending the articles. Once the website is alive, we'll give you the link for submitting the articles for our journal. We are going to have a proper abstracted journal in association with Walter Kluwer. So this is going to be a prestigious project for APOS. And I take this opportunity to request all of you who are listening and all of the respected panelists also to start contributing to our own journal in a small way so that we can take it to an index journal in the future. Thank you all once again for the opportunity, and thank you.
On behalf of the Visakhapatnam Ophthalmic Association, thank Anil, Chairman ARC APOS, Madhu for coordinating the program, and all the speakers, Raghava, Ramya, Padmini, Nasreen, and Sunil. Thank you very much. Thank you, micro team.
Thank you very much, sir. Thank you very much for giving you a great opportunity.
Madhu, myself, and then Anil, and then all the micro team. Still morning we are sitting. So we need to stretch our legs before we develop a deep vein thrombosis. Okay, bye. Have a great day.
Thank you, sir.
From ARC, we thank Vizag Ophthalmic Association for taking up the webinar. And thank you, Madhu, for organizing it very nicely. And thank you, Micro-Vision, for doing a very good job. Thank you. Thank you, one and all. Thank you all the cornea surgeons, one and all, who have done an excellent job today. And it was very useful and very, very scientific material. And it's very useful to postgraduates. Thank you so much.
Thank you, sir.
Thank you, sir.
Thanks, everyone. Thank you, everyone.
Good night. Good night.
Good night, sir.
Good night.